All right. Good afternoon, everyone. Welcome to the Health Coverage Insurance and Financial Services Committee. This afternoon, we have 4 public hearings, and then we are going to do some language review if we have time. Before we get started, we'll do introductions, starting with Representative Chimino.
Thank you, Madam Chair. Hi, everybody. Welcome. My name is Representative Mary Grace Chimino. I represent House District 83, which includes Bridgeton, Harrison, and Denmark.
Good afternoon, Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good afternoon. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springvale.
Good afternoon, everybody. Paul Flynn. I represent House District 63, which are the towns of Winslow, Albion, Freedom, and Unity Plantation.
Good afternoon. I'm Rolf Olson, District 86, which is Raymond, Casco, Fire Island, and a bit of Poland.
Good afternoon. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good afternoon. My name is Christy Matheson. I represent Kittery District 151, and I serve as the House co-chair.
Representative Morris, did you want to introduce yourself? No, he's just sitting down.
Thank you. I Representative Josh Morris, represent House District 91, which is Turner, Leeds, and Wayne. Thank you.
All right. And I am Senator Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair of the committee. We are going to start today with the public hearing on LD 2056, an act to provide additional financing options to consumers in the state. Senator Curry, welcome.
Senator Bailey, Representative Mathiasen, and esteemed members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Chip Curry. I have the honor of representing the 26 rural, coastal, and island communities of Waldo County in the Maine Senate. Thank you for this opportunity to present on LD 2056, an act to provide additional financing options to consumers in the state. I put this bill in on behalf of and at the encouragement of the Ford Motor Company, which has a representative here for us today. They have a financing product that they currently use in many other states, and they believe it offers consumers greater flexibility. However, it currently conflicts with Maine's consumer credit laws. This proposal would allow a simple interest loan in which scheduled payments may vary within a reasonable limit rather than being required to be nearly identical each month. Importantly, the full payment schedule would be clearly disclosed to the consumers at the start of the loan and agreed to upfront. So this does not open the door to creditors changing or increasing payments later on. I believe this approach still meets Maine's strong consumer protection standards while creating another safe, regulated option in the marketplace. In a rural state like ours and in a district like mine, access to reliable transportation is essential. People need vehicles to get to work, medical appointments, school, and basic services. When we can responsibly expand financing options, we can potentially lower costs and help more Mainers access the vehicles they need. Thank you for your time and consideration. I'm happy to answer questions, but also recognize others are in the room behind me that will be able to answer more.
All right. Thank you. Questions from committee members? Representative Mastracchio.
Thank you, Madam Chair. So just explain to me again, this is like a interest rate that changes?
It's an auto loan that has a set price for so many months, and then it goes up to a different interest rate afterward. And the representatives could describe that.
Oh, okay, so I'll wait till somebody else comes up
Yes,
and make it.
and I believe it's 45 other states that allow this product.
Thank you.
Further questions? Representative Arford.
Thank you, Madam Chair, and thank you for being here with us, Senator Curry. When you say 45 other states have the product, is it the exact same product? I mean, as this is written out and would be offered here in Maine, or are there some, discrepancies here and there in terms of what the 45 other states offer?
Thank you, Representative Ufford. That is an excellent question, and I will not venture to answer it. I think so, but the people who really know this are behind me.
Thank you.
Thank you.
Further questions? Seeing none, thank you very much.
Thank you. I apologize. I do have to leave for another committee.
Thank you. Anyone else in the room wishing to testify in favor of this bill? Please come forward.
Good afternoon, Senator Bailey, Representative Matheson, and the distinguished members of the Health Coverage Insurance and Financial Services Committee. My name is Michelle Elder. I'm the Regional Director for State Government Affairs at Ford Motor Company. And on behalf of Ford, I want to thank you for this opportunity and also thank Senator Curry for presenting the bill. And I'm testifying today in support of LD 2056. Currently, Maine law requires installment payments to be substantially equal, and this requirement makes Maine one of 5 outlier jurisdictions in the country that effectively prohibits a flexible program called Ford FlexBuy. Ford Credit, the financing arm of Ford Motor Company, has offered this program since 2004, and it is presently offered in 45 states. FlexBuy offers a payment structure focused on providing lower payments for the first 3 years of the contract compared to the standard financing, providing consumers with greater flexibility to manage their budgets. FlexBuy operates like a traditional retail financing loan with a fixed interest rate and customer ownership. But it distinguishes itself with an unequal payment structure, lower payments for the first 36 months, increasing at month 37 to ensure that the balance is paid in full by the contract term. FlexBuy is typically offered with 66 or 75-month terms, and there are no prepayment penalties. As vehicle prices rise, affordability is a growing concern, and this structure helps consumers, such as the recent graduate or those early in their careers, manage their budgets with lower initial payments. And we also find that many customers choose to trade in their vehicle when the payment increases because they own their vehicles. And this allows them to move into a newer model. The proposed amendment would bring Maine's law into alignment with the majority of other states. And by doing so, it levels the playing field for Mainers, granting them the freedom to determine the payment amounts that best meet their financial needs. This bill does not remove consumer protections. In fact, FlexBuy contracts are designed to ensure that consumers are aware of their payment obligations for the entire term of their contract and are not required to pay additional fees. And our data shows that FlexBuy customers perform almost identically to those with our standard contracts. So this is not a higher risk product. This is simply a flexible one. So we respectfully request that the committee advance this legislation to empower Maine consumers with more financial choice. I'm happy to take further questions.
Good, thank you. Questions, Representative Clutch.
Thank you, Madam Chair. I have 2, if that's okay. So the rate, I just want to make sure the rate doesn't change throughout the life.
Correct. It is a
Just the
fixed
amounts that
rate.
change. Okay.
Yep.
And then you mentioned that there's a lot of people that will sell their vehicle when the payment increases. So I'm curious, do you have data on how many people that do choose to sell are underwater when they choose to sell and therefore have to like roll over, debt into a new vehicle?
So I don't have that data on me today, but in terms of underwater, FlexBuy is no different than any other vehicle loan. Rollover, equity is not unique to this program. The default rate is identical to that of our standard loan, and it's very low. It's around 1%, and most of it happens within not even near the 36 month. It's early.
Further questions? Representative Flynn.
Thank you, Madam Chair. Ms. Zelda, thank you very much. In this scenario, if someone comes in and you're going to, the first 36 months are lower payments, and then the payment goes up. At what payment are you pre-qualifying them on for their debt to income ratios? The lower payment or the higher payment?
The qualifications for the application of this program is identical to that of the standard loan. So if you qualify for the standard loan, you qualify for this. If you don't qualify for the standard loan, you do not qualify for FlexFi. So
But if I come
Yes.
in, are you going to pre-qualify me on what the payment's going to be at month number 66? Or are you going to pre-qualify me on the payment at month 30?
it would be the same.
The payment stays the same.
No, the qualification of the loan stays the same. The payment structure changes at month 37. It increases
Right.
once.
Right. So my question is, at month number 1.
Yeah.
When I come in to buy a Ford product, are you running my debt to income on the higher ratio
No.
or the lower ratio?
No, neither. It's if you qualify for the standard loan, then you have access to this one.
Further questions? Representative Matheson.
Thank you. So I'm just looking at your schedule. And it looks like the differential between this example is only like $84. Do you have any stats for maybe the work session to show us what this differential payment is typically for somebody? Like, is there a big sway from 36 months to 37? Is there an average or?
Yeah, so that is an actual realistic scenario because this is a subvened loan. So which means that Ford Motor Company pays down that interest difference for credit to be able to offer that. So that 0% APR in that example in your packet is an actual real-time case scenario. But yes, we're happy to,
That'd be
provide
great.
more information.
I'd just be curious what that differential is from 36 to 37 typically for someone who comes to you that does this loan. I'm just trying to get a feeling for how much do these loans jump from week 36 to 37 for your average person? Or is that just all over the map because the price of a vehicle is?
Yeah, it just depends on the amortization schedule. So you're essentially adding 6 months to that 60-month loan, giving people
Got
a
it.
longer option to pay that off.
Okay. Just one quick. And are your average loans 5.5 to 6.25 years? I mean, because you said they're either 66 or 75-month terms, which is about 5.5 years or 6 years. Is that your typical auto loan?
I don't know that. I can get back to you on that.
It seems like it's a short amount of time to me from what I understand for auto loans. Thank you.
Okay. Further questions? Representative Alford.
Thank you, Madam Chair, and thank you for being here. You're saying that all Ford dealers in Maine will be offering this product if we were to pass this bill into law. And currently, none of them are offering the program.
Correct.
Have you come to Maine previously with the same program and asked that it become law? Or is this your first time here?
My personal
Well, the Ford-
no,
the-
I don't believe that Ford has come. I will double check on that. So this program's been around since 2004.
Mhm.
I've been with the company a year and a half.
I'm
But I
just
do not,
curious.
I do not think that Ford has asked to address this before.
Okay, and I'm just curious as to, so it's in how many other states again?
45.
And when did you, and you started offering it in 2004? And it just, you built up all those states, or did you board them all at the same time?
It depended on the state's codes and laws. Some states allowed it. And some states like New Hampshire did not allow it, and they updated their codes last year so that now it's allowed in New Hampshire.
Okay. And I'm just curious, why wait that long to come to Maine?
I found out about it a year ago and I saw that Maine was on the list
Yeah.
of prohibited lists. And I said, that's one of my babies. I want to
Yeah.
go and see if there's
Okay.
interest in making vehicles more affordable.
So if I was to go to Ford, buy a car, use this program to finance my vehicle, and I decided to pay off at the 37, say 36, 37 month period, that amount you're showing, I'm looking at your schedule, you're showing the amount you pay off. But that does not include any of the forward interest. It's you're paying the principal and all the interest up until that point in time, but not any of the interest that would be paid if you did not pay it off at that point in
Right,
time.
it's math, right? It's no
Okay.
different than any other auto loan. The interest total depends on how much principal you have over that time period.
Okay, great. Thank you very much. Further questions?
None, thank you.
Thank you.
Anyone else wishing to testify in favor of this bill? Please come forward.
Good afternoon, Madam Chairs, and members of the committee. Thank you very much for allowing me the opportunity. My name is Kevin Tessio. I'm representing Darlings Auto Group. We have dealerships in Ellsworth, Bangor, Newport, Augusta, and Brunswick. We employ over 650 people in Maine, and I am speaking in strong support of LD 2056. Every day we work with families who need reliable transportation, certainly something that's needed in work, to get to work, bring children to school, access healthcare and essential services. And for many of these consumers, the biggest obstacle to getting dependable transportation isn't often the vehicle itself, but it's having affordable financing. This bill is important because it will modernize Maine's consumer credit code to allow these flexible payments. Right now, creditors in Maine are prohibited from offering loans that where payment schedules are not substantially equal. So with this change, Maine residents are effectively denied access to programs. And by the way, if other lenders want to offer this program, I mean, we're talking about the Ford program today, but there are other lenders that undoubtedly would want to do that. It allows the consumer to have something that better meets their financial needs, particularly in those first few years of ownership. The monthly payments, I think, as mentioned before, could be substantially less, in most cases 15 to 18% less in those first 3 years. And this program isn't experimental. It isn't untested. As said, it is already happening in 45 other states. And we feel that this results in Maine consumers being placed at a disadvantage. If a Maine consumer wanted to take advantage of this, they couldn't do it in the state of Maine. It's not good for Maine consumers. It's not good for Maine businesses. And this really would allow consumers to have the same financing tools that is widely in use across the country. It would let us keep our consumers right here in Maine. And it's really about fairness for the consumer and making sure that they're not left behind. I respectfully urge the committee to take action on this and support LD 2056, and happy to answer any questions. Thank you.
Thank you. Representative Mastracchio.
Thank you, Madam Chair. So we don't offer the product now. That means nobody offers any kind of balloon financing or, at all. So if somebody comes in and the payment is high, are they choosing a lease instead? Because I mean, seeing those advertised, sometimes that monthly payment looks like a whole lot less than $600.
They absolutely would have to look at all the options. Sometimes that is a lease. Sometimes it's the consumer getting a, less expensive vehicle. Sometimes it's the consumer having to put more money down, those kind of things, or a longer term.
Representative Flynn.
Thank you, Madam Chair. Does your down payment requirements for this particular product, are they similar to a traditional product or is there more required with this?
They're identical.
Representative Chimino.
Thank you, Madam Chair. Hi. Do you have any idea how much business is being lost by people that will then know about the program that's offered maybe in another state and they go to an adjacent state to be able to purchase?
I honestly couldn't give you, I wouldn't know. I would suspect that it's substantial, just because it's what we hear from consumers. It's always about the monthly payment. So I would suspect there's some lost.
Representative Arford.
Yeah, so I was wondering, by the way, thank you for being here and thank you, Madam Chair. I was just wondering, of these 45 other states, do you have the data on how many loans annually of this Ford Flex program, how many loans they actually do write?
I don't have it right in front of me, but I'm sure
I'd be
people from Ford
interested
could
in
get it
seeing,
for us.
because that would also speak to how much business might be lost here in Maine.
Absolutely. Yeah, we'll
If
make
it's
sure
really
that you get
A high
that, so.
utilization product.
Yep.
Thank you.
Okay, further questions? Representative Foley.
Thank you, Madam Chair. Do you know, does New Hampshire offer this?
Yes, they're one of the states that just came on board. They made the change to their consumer code, I think late last year, 2025.
So if I went to New Hampshire and bought a Ford product, I could get that in the New Hampshire dealership, but I can't do it in Maine.
That's correct.
Thank you.
Further questions? Representative Arford.
Thank you, Madam Chair. I'm just curious, does Maine, I just find this so interesting that this product has been around since 2004. 45 states have it, and yet this is the first we're hearing of it here in Maine. It's just as interesting to me. And so do we have a similar product that we've been offering here or something that's comparable to it?
Not that I'm aware of,
Thank you.
fortunately.
Further questions? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify in favor of this bill?
Senator Bailey, Representative Matheson, and members of the committee. My name is Jay Darling. I represent Darling's Auto Group. We're in, as Kevin said, we're in Brunswick, Augusta, Newport, Bangor, and Ellsworth. I'm in support of LD 2056. I guess rather than say everything I already said, I do have a couple of answers for you. I spoke to Ford Motor Credit before I came, and in New England, which is Connecticut North, it's about 5% of their overall loan business. It tends to be more when you have cemented rates like 0% financing, things of that nature, because it makes a bigger difference. People keep their vehicles a little longer rather than just have a higher interest rate. If you get 0% interest rate, you keep your car longer. And yes, somebody's here from Sanford, so you can buy a car at in Saco, or you can go across the bridge and get one in Dover or Portsmouth and be able to get this same product. So to answer some of the questions, when you apply for the credit, you apply for the loan, you then have the decision whether you want the flex buy or not. There's no credit decision difference based on a lower payment or a higher payment. It's you get approved for credit, then you choose which program you'd like. I think I answered most of the questions. Anyone have any questions of me?
All right, any other questions from committee members?
And it's not a balloon. It has an amortization schedule,
Right.
and the interest rate doesn't change.
It's not like an arm in a mortgage.
That was going to be my question, the balloon, but I also just want to say that I'm from Kittery, so you can go into Portsmouth much easier than Sanford.
Yes, yes, or you can, you can be in Wiscasset and the same owner owns the one in Portsmouth and you can send them down there rather than buy it here.
Yeah. Further questions? Representative Arford.
Yeah, thank you for the statistics you just supplied. So I am also curious, the 5%, you were referring to nationwide of folks who use this particular financing product?
No, in the New England
Oh,
zone,
in-
which
oh,
is
that's right.
Connecticut North, it's
So-
5% of the overall.
So that
loss.
would equate to like how many vehicles? How many vehicles are
You're
sold?
testing me. Well, it's not only how many are sold, how many are financed with Ford Motor Credit. So I don't have that answer. I think
Yeah.
the New England Ford dealers sell about 5,500 to 6,000 vehicles a month. So that'll give you a little bit. But when you have like a 0% interest or something, it might spike up to like 10 or 12 or 15%. And in months where there's not any cemented rates,
Mhm.
it's probably lower.
Thank you very much.
You're welcome.
Further questions? Thank you very much.
Thank you for your time.
Anyone else wishing to testify in favor? Oh, we have someone else coming up. Oops, sorry.
No. You were just a little bit bigger. Don't be too proud of that. You have a lot of years.
No, you have 20 years on that. Didn't say it on it.
All right. Good afternoon, everybody. Senator Bailey, Representative Matheson, and the members of the committee. My name is Amanda Johnson. I'm here on behalf of the Maine State Chamber of Commerce, and I represent more than 5,000 employers across the state. I am here today to express our support for LD 2056. Currently, Maine law requires that consumer credit payments be substantially equal. While well-intentioned, this rule has the unintended effect of limiting flexible, simple interest financing options that are widely available in many other states. This means Mainers have fewer choices and often face higher monthly payments, particularly when purchasing a vehicle compared to consumers elsewhere. Importantly, Maine law already allows lenders to extend loan terms to lower monthly payments, but this often comes at the cost of paying significantly more in interest over time. Unfortunately, this has become a more common financing option for auto loans as the affordability of buying a new car or used vehicle has become a challenge for Maine residents. LD 2056 offers a more innovative approach. It allows modest variation in payment amounts for simple interest loans, so long as no payment exceeds 50% of any payment. This gives consumers short-term relief when they need it most, without increasing the total cost of credit. It may be the difference for consumers to have access to a car that is an absolute imperative for a job in Maine. This bill does not weaken consumer protection. It does not permit balloon payments, hidden fees, prepayment penalties, or unfair lending practices. States that already allow this type of flexible financing model, similar to traditional loans, show that consumer protection remains strong. Allowing this modest flexibility has real tangible benefits. It improves affordability, especially in the early years of a loan when families are juggling other expenses. It preserves access to simple, transparent financing options that are easy to understand. It reduces unnecessary regulatory barriers that discourage lenders from offering competitive products in Maine. It empowers consumers to choose payment structures that fit their income and financial goals. By clarifying and modernizing Maine's consumer credit laws, LD 2056 would align our state with many others, ensure Mainers have fair access to responsible financing, and maintain strong consumer protections. For these reasons, the Maine State Chamber of Commerce urges you to support LD 2056. Thank you for your time and consideration. And I will try to answer questions as much as possible.
All right. Thank you. Questions from committee members? Representative Matheson.
I think I have kind of the same question about you indicate modest variation. I guess I just need a better clarification on what those variations usually are with these flex loans, because I know my 23-year-old who doesn't own a car.
Right.
And gets into this type of a relationship, who knows in 3 years if the income level is going to increase to that point in time. So I guess I'd like to have some clarifications on what that modest variation is. If there's
So-
any.
I can refer to the the Ford folks for that question in particular. I guess my take on this is the first 36 months are less expensive. So if someone who's getting out of college, has just started a job, maybe paying down some of their college, and this is just my opinion. I have young adult children myself, so sometimes say they had a baby or something and they need a car to support that, to go to the doctor's appointments. And they plan on going back to work, but in the first few months they don't, or first few years they decide to stay home with us. And then they know they're going to go get a job after that. That savings could potentially help them out those first few years. That's my opinion.
Thank you.
Yeah.
Okay, further questions? Representative Harford, if you could turn your mic off. Thank you. The questions? Okay.
That's it.
All right, seeing none, thank you. Anyone else wishing to testify in favor? Now Bruce can come up. That's why is this happening here?
Yeah. Yeah, no more than 50%. Yeah. Yeah.
It was, yeah, not gone right. It gives them a little bit of regard to that, right? Right.
Yeah. Yeah, that's a good point.
Senator Bailey, Representative Matheson, and members of the committee, my name is Bruce Garrity. I'm here on behalf of the Maine Automobile Dealers Association, which is the association of all new car and truck dealers in the state of Maine. You've basically heard most of the testimony, but I would like to make one point and then give you a little bit of personal experience that I think could help as you look at this. Dealers have financing departments. It isn't just a matter of going, if you're a Ford dealer, to Ford Motor Credit. There are dealers who have relationships with banks all across the country. It is not uncommon, for example, for a dealer to know of a bank in Houston, Texas. And I actually had this situation several years ago where a rate was being proposed that was more reasonable or less than you can get in New England or some other part of the country. Many of those are tied to changes in the interest rate. Those aren't available even if dealers are shopping for the benefit of the consumer to get them the best deal because the dealer wants to sell a car. And those aren't available in a way that they would be with this bill passing. So I hope that's another point for you to consider, that dealers are essentially deprived of using their expertise in many instances in helping consumers be able to afford vehicles. The second point, and it's just a quick little note, I came back to Maine with my wife in 1979 after law school. And we did have 2 nickels to rub together, but you couldn't find a quarter on top of that. And my first loan, we were able to get a house, but just barely. And my first loan was $230 a month, which may sound pretty cheap right now, but we're talking 1979. And we could barely afford it, but we did. And a couple of years later, I was lucky enough to get a raise or two. And all of a sudden, wow, we can afford this, and we can go and get a car better than the one we had coming out of law school. I was very proud to be able to keep that on the road, but that's about all I could do. And I think that helps a lot of different people one way or another. Either you wait and then you can afford a car, or you can afford a car with a lower payment while you're struggling to grow. But the important point is, as your income increases, all of a sudden things get more affordable. So if you have a rate that changes over time, it becomes a more affordable rate when that changes. And with that, Senator, I'd be happy to try and answer any questions the committee might have.
Thank you. Questions from committee members? Representative Foley.
I think it would also be helpful for folks, because when you first buy a car, the excise tax is far greater in the first couple of years and it goes down. So this would certainly be beneficial for that upfront amount of money. Wouldn't that be true?
Yes, it would. And as an aside, I'll just pass this along. The single greatest source of sales tax revenue in Maine every year is the sale of cars. So it's an important part of our economy on top of that. Thank you, Senator and members of the committee.
Any further questions? Representative Arkford?
Oh,
Yeah, this may have already been mentioned, and if it was, I did not catch it, so I'm going to ask again. Do you know, is there a specific default rate attached to this particular type of loan?
I honestly don't know. My personal guess, and it's all it is that there wouldn't be much difference. I think there are people who buy a car that they really couldn't afford and it catches up to them relatively early. I suspect there will be fewer cases of people not being able to handle it as time goes on, but I don't know that.
Thank you.
Okay. Further questions? Representative Flynn.
Thank you. Bruce, you'll have available for the work session some of the data on the deficiency rates, delinquent rates, pre-approval rates, all that stuff when we get there.
We'll do the best we can to get
Thank you.
information for you.
Further questions? Seeing none.
Thank you.
Thank you. Anyone else wishing to testify in favor of this bill?
I already testified. I have the answer to your question.
Oh.
The choices are 66 months and a 15% decrease in the first 36 months, 66 months and an 18% decrease, or 75 months and a 15% decrease. Then it would go back the other way. That's the current program.
Good. Thank you.
Thank you.
Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against?
Good afternoon, Senator Bailey and Representative Matheson and members of the committee. My name is Linda Conti and I am the Superintendent of the Bureau of Consumer Credit Protection, and I'm here today to testify in opposition to LD 2056. This bill amends Maine's longstanding requirement that any one loan payment must be substantially equal to other loan payments. This means that in Maine, consumers can rely on their monthly payments being equal. Proponents of the bill, Ford Motor Credit, wants to offer a specific product in Maine that allows for smaller payments at the beginning of the loan with the larger payments at the end of the loan. While this would allow more consumers to qualify for and afford a loan potentially early in the life of the loan, it also sets up these customers for failure as their monthly loan payments increase at the same time that the value of the vehicle decreases. So the loan becomes, the monthly payment becomes higher at the same time that the car starts to need more work on it and becomes less valuable. I'm concerned that the benefits of the program will be outweighed by the harm to the consumer who cannot make the later payments, the increased payment amounts at the end. I'm concerned about throwing out a perfectly good statute for one specific product. I guess I'm not concerned about people who are buying those great big expensive Ford trucks that you see that cost like $75,000. I don't even think those trucks, truth in lending doesn't apply to vehicles that are over like $80,000 or whatever. I'm concerned about smaller consumers getting sucked into vehicle payments that they can't afford later on. And that's all I have. Maine is one of the few remaining states that don't have this law. I know Ford's been putting a big push on around the country for this. So that's where it's coming from.
Okay, Representative Flynn.
Thank you, Madam Chair. Thank you, Linda. Is the concern of the Bureau is concerned that the benefits of the program will be outweighed by the harm to consumer who cannot make the later increased payments? Is that based upon hard data that you've received from other states that are involved in this, or is this your feeling?
It's based on my common sense. I'm just a girl from Washington County, Maine, who hates to have a long car payment, who does not want to be paying, that's just how I was brought up, basically.
Thank you, Linda. That's my concern, but at the same time, what I'm trying to get at is the metrics. What's it like in other states, and what are some, there's probably more work session related stuff, but
Possibly. I mean, we have been talking about things like we could limit this to not being applied to used cars. We could limit this to, if you do this, you give up your self-help right to repossession. I mean, there are things that could be done maybe on the back end of this. I don't know, but it's just a gut concern. It's not anything that I can point to that in statistics that will answer the question. I'm concerned about the poorer people.
Representative Matheson.
I think this is probably for the work session, but I'd be really interested in knowing if default rates went up in the states that allow this for car loans. So maybe that's probably nothing. I don't know. Is that something that your department can do, or is that
I can
something-
ask around.
Okay.
I can ask the NCLC. I can ask some sort of agency like that if they know. They may not know. I don't know. You'd have to be looking at, well, the companies would have the data. They would be the best source, I think.
Further questions? Representative Arford.
So thank you, Madam Chair, and thank you for being here. I'm just a girl from Auburn, Maine, but I think the same way you do. And one of the things I'm still mystified at, that we are one of the 5 remaining states since 2004 to even consider this. So has there been something similar to this considered that would have changed this statute in the way that this bill is proposing to change it? Have we ever considered doing anything like this in statute? Or is this really the very first time?
Well, this particular law is really, really old. It goes back to the original Consumer Credit Code that was enacted back like in the 70s when these things first came into place. And there were no national credit cards. I mean, it was really a state by state. Each state had its own credit regulations. So this really hasn't been looked at in a long, long time. And it may be something that needs to be looked at. And, I'm willing to look at the Consumer Credit Code, but my preference would be to sort of look at it as a whole, as opposed to picking away around the edges of it. I see this as, rather than a reconsideration of where we are at with the policy, it's more like death by 1,000 cuts. We're just chopping away at it here and there. And that may just be my naivete and idealism because it's not perfect. The legislation making process is not perfect, but that's my view of it.
Okay. Further questions? Representative Chimino.
Thank you, Madam Chair. Thank you. So hypothetically, I have a car, I make the payments, I'm under this program. I
Mhm.
make the payments for the 3 years. And now on that payment, that next payment where the price goes up, I'm not able to make that. So I decide I want to sell my car because the car is mine. But now it's probably depreciated and I owe more on that vehicle than what a bank is going to cover. In other words, if I did a used car loan, if I wanted to refinance it, that's where I see the problem. I'm concerned that if I went to refinance, that no bank would cover it because the collateral isn't there with the vehicle.
Well, that's another question. You would probably, these people have that coverage, that special insurance coverage, and probably Ford Credit sells you that coverage too, that takes care of when you get upside down in the loan. So that would be a good question to ask too.
So it'd be more like a rollover. You roll it
Yeah.
into the next payment. So then you're always the way you do with the lease.
Mm-hmm.
Okay. Thank you.
Further questions? So, are you willing to talk with the representatives from Ford to see if you can come up with some guardrails? I mean, you had mentioned a few possible suggestions. I mean, I think that we do want to make sure that the consumer is protected. But if there's a way we can do that and still advance this program, are you willing to have those discussions?
Yes, if that's the wish of the committee.
Well, it's the wish of the chair of the committee.
Well, that's
the whole committee.
that's close enough, I guess. That's good.
You can do with that what you want, but.
Thank you.
Any further questions? All right, thank you.
Thank you.
Anyone else wishing to testify on this bill? Any other requests for the work session? Representative Clucci.
Thank you, Madam Chair. So for anybody who's in the audience that is in the car dealing business and loan making business, I would be very curious to understand what, how much money is rolled over for people who are buying new vehicles with this program. Coming out of a program like this, when they buy a new vehicle, what is the amount of money that they are rolling in because of negative equity versus people that are not coming through this program, right? So if they've had a traditional loan, because I'm curious about, is this exacerbating people's negative equity problem? Thank you.
Okay. Any further requests for the work session? Seeing none, I will close the public hearing on LD 2056. And we will open the public hearing on LD 2088, an act to increase access to primary care provided by physician associates. And that is Representative Boyd.
Do I have to sign in? I don't remember. Do I sign in? It's been a while since I've been on this side. Okay, good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Michelle Boyer and I represent District 123, part of Cape Elizabeth. It's an honor to come before you today to introduce LD 2088, an act to increase access to primary care from physician associates. We all know that Maine currently faces a healthcare staffing crisis. As of now, more than 85,500 Mainers live in areas with a shortage of health professionals. LD 2088 provides this committee and this legislature an opportunity to be part of the solution, to create more job opportunities within the health field so that Mainers can access the care they need when and where they need it. First, let me give you a little background on physician associates, better known as PAs. These medical professionals are nationally certified and state licensed. They diagnose, treat, and prescribe across a variety of specialties and settings and are always patient-facing. They are rigorously educated and trained effectively to deliver high-quality care. When PAs are able to practice at the top of their licensure, it provides patients the ability to access timely care, reduces avoidable delays, and helps to stabilize health systems across the state. PAs are qualified to provide comprehensive primary care, disease management, and behavioral health services, particularly in underserved areas. However, when PAs are only permitted to deliver care per a practice agreement with a physician, we limit their ability to practice at the top of their licensure. LD 2088 would update Maine's PA law to remove restrictions on PAs practicing in specific settings where a physician is not a partner. Current law requires a legal relationship with a physician called a practice agreement whenever a PA practices in this one specific setting. in a hospital or other healthcare system or in a practice where a physician is already on staff, a practice agreement is not required by law. With hospitals and health centers closing, access to medical care is becoming more of a challenge, especially in the most rural parts of Maine. PAs are valuable clinicians ready to meet the medical needs of impacted communities. They should be able to do so, just as nurse practitioners already can, without additional barriers like having to find a physician willing to sign on to a practice agreement. Maine law has allowed nurse practitioners, also known as NPs, to practice independently of a physician, regardless of setting, for over 30 years. So why don't we create parity in our workforce and allow PAs the same? When we create more opportunities for PAs to practice, we create more job opportunities, and that has the potential to attract more talent to the state. And anything we can do to encourage healthcare providers to stay in Maine or move to Maine is well worth this legislature's efforts. Briefly, let me walk you through the bill. LD 2088 begins with an emergency preamble. If there's consensus from committee, I think it best to allow these changes to become effective immediately. However, if we perceive it's a risk to the bill's successful enactment, I'm totally open to having the preamble be removed. The first 4 sections of the bill make changes to Title 32 governing osteopathic medicine. You'll see that sections 5 through 8 mirror those changes in the law governing allopathic medicine. Sections 1 and 2 both remove reference to and the definition of the PA practice agreement. Section 3 makes the necessary changes to the existing PA consultation requirements to avoid a conflict in the absence of the practice agreement requirement. I want to stress here that collaboration is intrinsic to the PA practice of medicine. These changes make clear that PAs will continue to consult when necessary based on their education and training and the practice setting or the system of credentialing and granting of privileges of the healthcare facility. Finally, Section 4 removes the practice agreement requirement itself. As I noted, Sections 5 through 8 make these changes in the allopathic section of the law. Lastly, I want to stress this bill maintains the requirement for physician collaboration with new graduates who have fewer than 4,000 hours of clinical practice. Nothing changes these first 2 years of close collaboration with physicians and other clinicians for PAs fresh out of school. Thank you for your time. Happy to answer any questions.
Okay. Questions from committee members? Seeing none, thank you very much.
Oh, you guys were easy on me. Thank you.
Others wishing to testify in favor of this bill?
Okay, come.
Welcome. Thank you. Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Service Committee. My name is Elizabeth Getchell. I'm a resident of Carmel and a physician associate practicing cardiology in this state. I am submitting this testimony in strong support of LD 2088. I have spent years practicing cardiology and managing patients with complex cardiovascular disease, hypertension, hyperlipidemia, diabetes, and other chronic conditions that require ongoing relationship-based care. Over time, PAs develop deep clinical judgment within their specialty. Yet, under current law, even experienced PAs are required to maintain a practice agreement with a physician regardless of years of practice, demonstrated competence, or the actual needs of the patients that we serve. This requirement is not based on experience, education, or specialty. It is simply whether or not a clinical setting includes a physician partner. In reality, this requirement does not improve patient safety. Instead, it creates a significant and unnecessary barrier to care. Finding a collaborating physician who is available, trusted, and aligned is often difficult, particularly in Maine, where many physicians are overextended or do not reside in the communities they serve. When an agreement is secured, it often comes with substantial monthly cost. In my case, this requirement adds approximately $800 per month in fixed overhead solely to satisfy a regulatory requirement, not to enhance patient care. Those resources could instead be used to expand access, reduce patient cost, and support preventive and longitudinal care. In cardiology especially, early intervention and risk reduction can prevent hospitalizations and save lives. LD 2088 would allow experienced PAs to practice to the full extent of their education and training while maintaining fully accountable through licensure, scope of practice laws, and professional standards. Eliminating mandatory practice agreements would remove outdated barriers, help retain skilled providers in Maine, and improve access to care, particularly in underserved and rural communities. As I work to open a preventive cardiology practice in my own community, the requirement to secure a collaborating physician has been the most significant barrier to moving forward. This process is not about patient safety or clinical oversight, but about finding a physician willing to enter into this formal agreement, often with little involvement in day-to-day care. Despite years of experience, this requirement delays practice launch, adds unnecessary fixed costs, and limits access to timely care. Eliminating mandatory practice agreements would allow experienced PAs to serve patients sooner, reduce barriers to care, and practice responsibly in alignment with the needs of Maine communities. I respectfully urge you to support LD 2088.
Thank you.
Thank you.
Questions? Yes, Representative Foley. I'm sorry. Glenn.
Plain Foley, we're Irish, all the
Foley.
same.
Two Fs down there. Sorry about that. I was staring at you and looking at you.
No worries. Thank you, Ms. Getchell, for coming. Help me understand in the third paragraph. In my case, the requirement adds approximately $800 per month in fixed overhead, solely to satisfy a regulatory requirement. Who's that? What's the 800? Who's that paid to?
To the collaborating doctor and the business that I have an agreement with to find this collaborating doctor.
So to each case that you need a collaborating doctor, you pay them?
Not a case, but a doctor to collaborate with me in this agreement. They are not involved in patient care necessarily, but the way that the law states now, we have to have a collaborating physician to practice independently.
Right. So you have to be under their license, one might say?
It's not under their license never necessarily because there's no liability on the physician in the practice agreement.
But you have to pay them for this service.
Right.
And what is the average of that payment?
Between $800 and $1,200 a month.
Regardless of how many referrals?
Yes.
Okay, thank you.
Representative Arford.
Thank you, Madam Chair, and thank you for being here. I find it extremely helpful when someone who's actually going to be or doing the work comes to speak to us directly. I have a lot of questions, but I'm just going to offer two for right now. When you talk, could you just walk us through, you've told us a little bit about it, but your practice agreement that you've had now for how many years? Have you been an independent practice?
No, I am just starting a practice now. And the way that it states is that a PA that's in the hospital system does not need a collaborating physician, but where I'm going out on my own, I have to have this practice agreement. And it doesn't necessarily mean that the doctor has to be there day to day or, be involved in the patient care unless I have questions.
So if you could, I really get the gist of the structure, but what happens in that practice agreement? I mean, you find a physician who's willing to be your person, you develop a contract for payment, and then what? What actually transacts between the two of you?
If I need them, they're there for me, asking questions about patient care.
So could you give an example of an instance where you might need them to be there
Say a
for
patient
you?
comes into my office and I'm kind of out of ideas and out of resources on how to treat their hypertension. I would call up my collaborating physician who's available during business hours, and he would offer me help, basically.
And if you did not have that, and see, you're in independent practice now, congratulations, by the way.
Thank you.
But, and you do not have access to a person that's contracted with you in such a manner, what do you do when you get to that point where you're stuck?
Because I have years of experience, I would call up a trusted colleague and say, hey, do you have any advice for me? Or I would call the next person. And that's, that's what I would do. Yeah. I would call my colleague.
And final, so I really understand, is there a time factor? Because I am quite sure that most people in your position would have a number of colleagues, other PAs that they have professional reciprocity with in
Yep.
terms of asking questions, but they're in their own practice or they're doing their own thing. So you aren't contracted for them to be available to you
Correct.
in the time frame that you might need them.
Right.
Correct? Whereas are you contracted with this person to be available to you in the time frame you would need them to be?
Yes, and in my certain collaborating physician, there is a document in there that says this doctor will be available between business hours of whatever that may be. Yes.
And my only other
Follow-up
question,
question?
and I'm just curious about this, the payment, it seems like the payment for this service could be a barrier or something that
Yes.
is, certainly you're not looking forward to paying
right.
additional costs for your practice. Is there any limit? Is there like a limit on how much people
No.
could charge for a service like this? Is there an industry
Not that I'm
standard?
aware of. No.
Okay.
A company can charge whatever they want, basically.
Okay, thank you very much.
You're welcome.
Representative Clucci.
Thank you, Madam Chair. Your testimony says that this would allow it would allow experienced PAs to practice to the full extent of your education. Can you help me understand why not having a practice agreement interferes with what you're able to actually do?
Basically, the way that it's preventing me from opening my practice sooner, essentially. My education allows me to practice. In other states, they, don't have practice agreements like this. So I guess I can't answer it fully, but not having one would allow me to open my practice sooner, the overhead costs to allow, better access to care or better equipment. So it's really that cost that's the barrier.
Oh, boy, lots of hands. I think Representative Olson had his hand up first. Sorry.
Thank you, Madam Chair.
Sounds like Foley.
Sorry, I
Don't worry,
know,
Bob, I
I
was
know
gonna
Flynn and Foley.
Probably two questions here. You say other states do not have the same requirement. How many other states? would you
I can't
say?
answer that question. I think it's 4, but I can defer to our lobbyist to help after. I'm not exactly sure, but it's kind of a wave that's coming across the country because of the access to care.
And then the second part of the question is there a difference in your malpractice insurance rates here versus ones that do not have this requirement?
Couldn't answer that. I'm not exactly sure.
Representative Foley. Okay. Representative, I'm just going to call on those that haven't asked first. Representative Mastracchio, and then I'll come back to you, Representative Flynn, I promise.
Thank you, Madam Chair. So just remind me, can you immediately go into independent practice after you graduate, or is there a certain?
No, it's the 4,000 hours. So any new PA would not be able to enter into a practice agreement. You are required 4,000 clinical hours.
So 4,000 hours in practice with a physician
Yes.
before you can go into independent practice.
Yes.
And in independent practice, I think that what I'm understanding is it's the mandatory practice agreement, because I would expect that you would be collaborating with physicians
Exactly.
and other physician assistants, maybe nurse practitioners,
Mhm.
like the whole field to get, I mean, you're not going to sit there and just think nobody else can help you. I mean,
Right.
because I know the nurse practitioner that I go to communicates with physicians.
Yes, and that's kind of being a healthcare provider, basically.
Okay,
is having
so
that.
basically, we still are maintaining have no problem with how many hours was it again?
4,000.
4,000 hours. It's that the practice agreement, when you decide to go independent practice,
Exactly. Yep.
is a mandatory agreement.
Yes.
And they have to be available in current law at all times for consultation.
Right, during my business hours, yes.
And I can see that would be a problem. Okay, thank you.
You're welcome.
Representative Flynn.
Just a very quick question. Thank you, Madam Chair, and thank you. So if I'm hearing everything correctly here, this is costing you between $12,000 and $15,000 a year to have a referring physician. Right?
This practice agreement.
Thank
that's-
you.
Yes.
Additional questions from anybody? Seeing none, I just wanted to clarify, if someone is working as an independent physician's associate, still getting the terminology, in a hospital setting, they aren't required to have this practice agreement. So I guess I'm confused about how that works in a hospital setting, since they're not required to have that. Why aren't they required to have that? I guess is my question.
I someone may be able to answer that a little bit better, but I guess anecdotally is because we have a collaborating physician that we do work with no matter what, in whatever setting I've been in as a PA, you always have that colleague right there. So after that 4,000 clinical hours, it's not necessary in that setting because everyone kind of is right there with you. So that's probably part of the reason.
Great. Thank you very much.
You're welcome.
Thanks for your time.
Thank you.
Oh, yes, Representative Harper, sorry about that.
Yeah, thank you very much. These are great questions that everybody's asking. I think, if it's my understanding, because going back, we have this, since I've been here, there's been each medical profession has come before us for certain requests that get them closer and closer to independent practice unsupervised. And so this is what I see as being the PA profession coming now, saying we've evolved to this point. We feel that now we're ready for this. And so the key to all this, though, is that you're going to be practicing independent in your setting of a physician. That's the key. If you had a physician there, you wouldn't then need to also go and get a separate, even if it was a clinic out in the middle of nowhere.
Right.
You still would not need to go get another
Practice
collaborative agreement. You would be all set. And so do you see, I'm just going to ask you to level with us and be as honest as possible. Do you see any safety? I am huge on patient safety,
Yes.
like huge. That pretty much trumps everything for me. Do you see any potential, especially if this, because I also see that this is saying, at least in the way it's alluding to, that this will help get more qualified caregivers into our rural area where we don't have, we definitely don't have enough there now. So in these more rural areas that are more isolated, and there's now people practicing with a PA degree and they're skilled, et cetera. However, they have a PA degree. Do you see any safety, patient safety concerns? Would you have any?
Not necessarily, because even when I'm practicing in the hospital, though I don't have that collaborating physician, my physician is not always there anyway. And I know other colleagues who have worked in ERs where their physician may not be there. So it doesn't really make much of a difference. And so I think the education and the training and the standards that I uphold myself, I know where my limit is. And so if I ever need help, irregardless of a practice agreement, I would know my limits and call a patient, call a physician or a PA or an NP. So in my case, I can only speak for myself. There would be no safety concerns for me.
Thank you very much.
Thank you for your time.
Thank you.
Are there, we're just gonna pull one person in online because they have to leave. Edna, if you don't mind pulling over Miss Leclerc. Welcome, Miss Leclerc.
Hi, good afternoon. Thank you for pulling me aside. I'm at work taking care of patients and I want to get back to the patients if possible. So I appreciate that. Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. I am testifying in support of LD 2088. My name is Angela Leclerc. I'm a resident of Gorham, a physician associate, and I am the daughter-in-law of Ronald and Kathy Leclerc. I've been married to their son, Jason, for 25 years and have been a part of their family for almost 30. When I began my clinicals as a PA student 22 years ago, my family practice clinical was in Ron and Kathy's town of Jay. This was the same family practice clinic where Ron and Kathy had been cared for by Dr. Michelle Knapp for over a decade. She was the quintessential town doctor. During my rotation with her, she shared how uncommon it was for her to go to church or to go to the grocery store without patients stopping her to say hello or to update her on their latest ailments. This type of dedication to the community was one that provided exemplary care and continuity to patients with chronic and acute illnesses. Now, over 2 decades later, Dr. Knapp has retired and the clinic has transitioned to more of a revolving door of providers, many just there for 3 to 6 months. As you know, it's difficult to recruit and retain providers, particularly in rural Maine. I have been coaching my father and mother-in-law to ask the right questions when they saw a new provider at almost every checkup to make sure they were working in a longitudinal manner to improve their blood pressure and blood sugar control. Unfortunately, in January of 2025, my father-in-law suffered a life-changing stroke that left him with moderate aphasia and right-sided weakness. Following his hospitalization, he needed a provider who would see him regularly, become familiar with his post-stroke needs, whether it was medication or therapy, and truly invest in him as a person, as my father-in-law, to regain as much physical and emotional and cognitive strength as possible. My husband and I wanted him to have a provider who knew him, grew to know my mother-in-law, and understood what was important to them, as well as the challenges they were facing in rural Maine with limited access to rehabilitation and other resources. It was at this time last year that I reached out to my friend and classmate, Madeline Bessie, PA, practicing family practice in Industry, Maine, who I graduated with 21 years ago. She started practicing in industry following graduation, where she grew her family and laid down roots. She's been a pillar in the healthcare community, much like Dr. Knapp was, and the familiar provider that patients grow to know and love. She agreed to take on my father-in-law as a new patient. My in-laws called me on the way home from his first appointment to share with me how genuinely interested they felt that Madeline was in caring for them. They articulated that they hadn't felt that way since Dr. Knapp and could breathe a sigh of relief that Madeline would be there for them for years to come. We appreciate Madeline and the care she provides for Ronald, my father-in-law. We hope she will continue to care for him for years to come. We are concerned that she may be a solo practitioner if the practice were to lose their physician provider, and her practice may be limited due to the practice agreement requirements that one of my colleagues recently spoke about at this hearing. Madeline and many experienced PAs in primary care carry their own patient panel, providing all aspects of care independently. We appreciate her and other PAs who are providing true continuity of care and therefore better health outcomes in rural areas of Maine. And I thank you for your time in considering this important opportunity to increase access to PAs in primary care, and also for listening to my personal story. Thank you.
Thank you for your time. Are there any questions from committee members? Seeing none, thank you very much. Are there additional people in the room that would like to testify in favor of this bill? You. Welcome. Thank you.
Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Amy Caldwell. I'm a board-certified physician associate. I am an Oakland resident, and I practice medicine in Hollowell and Skowhegan. I'm testifying in support of LD 2088, an act to increase access to primary care provided by physician associates. For the past 15 years, I've been practicing medicine as a physician associate here in Maine. I devoted my first 12 years to emergency medicine and expanded upon the strong foundation of knowledge when transitioning into hospital medicine 3 years ago. More recently, with my desire to treat root causes of medical problems, I began to look into independent practice. I considered a blend of conventional medicine and a functional approach as a primary care provider. When explored further, I realized my limitations as a PA in becoming independent. As a result, I decided to focus my area of medicine with the assumption I'd be more successful in finding a doctor willing to sign my practice agreement. It wasn't easy. I had asked several doctors before I found one willing to sign my necessary paperwork. The physicians I approached knew me very well, were familiar with my fund of knowledge, my detailed note-taking, and my thorough medical decision-making. Those who declined explained that it wasn't clear that they'd be protected from potential litigation based on my actions, even though LD 1660, a bill that passed in the March of 2020, states PAs assume their own liability for their patients. I am licensed and insured for this coverage. I have met the criteria for hours and experience to work independently. Despite this, a practice agreement states that the doctor will be available at all times for consultation. This is impractical and something that most physicians don't feel comfortable with. Furthermore, the scope of practice requirements in the practice agreement limit my ability to practice to the full scope of my education and training, as well as address the evolving needs of my patients. I am ready to expand what I offer to my patients. Patients present with overlapping problems that I feel comfortable to address, but I must consider whether this is moving outside of my approved scope of practice per my practice agreement. I know I can update my scope and request further privileges, but I am not sure that the doctor who signed my initial practice agreement would be comfortable with this expansion, again, because of the concern for additional potential liability. In addition, when I was setting up my practice, I was not able to establish an account with a lab because they were insistent that I could not practice independently. Even after I cited LD 1660 and the agent on the phone agreed, the head of Quest Labs refused my account request. They only allowed me to open an account using my colleague's nurse practitioner NPI PHI, despite the fact that I had been practicing longer, have more experience, and had a license without any supervising physician since 2020. Lastly, what happens if my practice agreement physician suddenly dies, moves out of state, or decides to retire? Is my crucial work in closing the menopause treatment gap going to come to an end? What if I cannot find another physician able to take over? Is it unreasonable that the care I've been providing independently would now come to an end as a result of what happens to a physician signing my practice agreement? It is frustrating that while I face these limitations too and challenges in my practice, my nurse practitioner colleagues are able to start their own independent practices and open lab accounts without direct oversight. This contributes to the gap in care between two advanced practice providers, despite the fact that PAs are trained under the medical model. If this law passes, I will expand my practice to assist patients in achieving metabolic health, which in turn prevents many of the chronic illnesses the U.S. faces regularly, while at the same time assisting them with basic primary care problems. Thank you for your time.
Thank you. Questions from committee members? Representative Arford?
Yeah, thank you so much for coming before us to testify.
Welcome.
So just help me understand, you specialize in a particular area that is.
I'm doing hormone therapy, perimenopause, and menopause care right now. That may be expanding.
So after you went through your 2 years of physician associate schooling, did you have to take an additional something or other, a time period or specialized course or whatever to specialize in a certain area?
Well, number one, I went from school to emergency medicine so that I could get a large fund of knowledge. That was my goal, was to know a lot of everything. I was trained to be a generalist and I wanted to keep that knowledge. So the schooling, number one, I'm sorry, can you go back to your original question?
No, what I'm trying to understand is, like, I understand how an MD
Oh,
gets.
sorry,
to-
the specialist
To say
part.
they are, you know, like an orthopedic
Yes.
specialist or
Yes.
whatever. How does a PA? I
So
don't
we-
want to question you because I'm sure you're doing a super job of what you're
Yeah,
doing.
no.
I just want to understand how you
Sure.
got there.
Sorry, I lost. We do have certificates of added qualification. So there are areas of medicine for us. So I actually have that certificate of added qualification in emergency medicine. And there are other areas, hospital medicine, orthopedics. Hormone therapy is not one of them right now. And so I did additional training on my own under another physician who trained in Boston. So that was just on my own to get that specialized training. And then I have that group to go to when I have questions. So for me, having a physician sign who doesn't even do this area of medicine, I'm never going to go to this physician and ask them a question about this because this is not what they do. I have my own resources and I would go to the group that I trained under, who has a large group that I have always access to.
Okay, so but as a physician associate, you are able to say to your patients, I specialize in the hormone therapy, which I'm sure is in great demand. I know a
Yes.
lot of women who.
Because of the training, right, because of the
Just
additional
but
training.
there's no, the industry does not establish what that training looks like. You
I am-
establish that yourself.
Well, I also took an exam. I'm a menopause certified, certified practitioner, which is a national exam. So I have that added qualification as well, that I can say I took a national certifying exam to be this specialist.
Thank
It's
you.
the same, it's the same certifying exam that my physician colleague would also take to say that they do menopause care.
Thank you so much for coming to speak with us today.
You're welcome. Thank you for having me.
Additional questions? Seeing none, thank you very much for your time.
Thank you.
Welcome, Ms. Harper.
Hello, good afternoon. Representative Matheson and members of the committee. My name is Laura Harper. I'm a senior associate at Mooseridge Associates. I'm here today to read testimony on behalf of Rachel Matson, who could not be here today. So these are her words. My name is Rachel Matson. I'm a resident of Exeter. I practice primary care. Today I'm testifying in strong support of this bill. I strongly support advancing independent practice for PAs in Maine. This issue is not theoretical to me. It is personal, practical, and directly impacts my ability to provide care to patients in our state. As a doctor of nursing practice and owner of a primary care practice in Maine, I'm actively trying to hire PAs to meet growing patient demand. Like many practices, especially those serving rural and semi-rural communities, we are facing workforce shortages, long wait times, and increasing barriers to care. One of the most significant obstacles I have encountered is the cost of mandatory physician oversight, which in my current hiring scenario would exceed $800 per month. This cost is prohibitive, not because PAs lack competence or safety, but because the requirement itself creates an unnecessary financial and administrative burden. This oversight model is a barrier to care. It limits the ability of PAs to practice to the highest level of their education, training, and experience, and it restricts practices from expanding access at a time when Maine desperately needs more clinicians, not fewer. These costs do not improve patient outcomes. They simply divert limited healthcare dollars away from direct patient care. Maine has already demonstrated that independent practice works. Nurse practitioners have practiced independently in this state for 30 years with a strong track record of safety, quality, and patient satisfaction. There is no evidence that continued supervisory mandates improve care, yet there is ample evidence that they restrict access, particularly in rural communities where physician availability is limited. PAs are highly trained, skilled clinicians who are essential to Maine's healthcare workforce. Allowing them to practice independently would reduce barriers, support team-based care, and enable practices like mine to grow sustainably while meeting the needs of our communities. Independent practice is not about removing collaboration. It is about removing unnecessary regulation that no longer reflects modern healthcare delivery. Maine must continue to lead by removing these outdated barriers to care. Supporting independent practice for PAs is a logical, evidence-based, and patient-centered step forward. Our communities deserve timely access to care, and our clinicians deserve the opportunity to practice to the full extent of their training. And I thank you for your consideration and for your commitment to improving healthcare access in Maine. I can't speak for Rachel, but I do, full disclosure, as you probably already know, I represent the PA, so I'm happy to answer any questions I can, either take them back to Rachel, or if they have other questions, I'll try to answer those as well.
Thank you. Questions from committee members? Representative Morris?
Yes, thank you, Madam Chair. Thank you for being here, Laura. Obviously I've been on this committee for 4 terms, and I remember when this bill came up, the original bill. If you can just sort of briefly kind of how we got to this compromise, and then specifically why now with this specific proposal, and how it kind of compares with the nurse practitioner. And if you want to bring something back for the work session too, that's okay.
Well, let me take a shot at it now.
Okay.
But I might take you up on the offer to also
Yes,
follow
because I
up.
know it's I remember this being a long debate, and we did
Yeah.
arrive at it unanimously. So
Yeah. So for those who weren't here, I mean, it was a bill that was carried over. We did stakeholder meetings, like we really did stakeholder meetings, in between sessions. They continued on through the second session. It was really some of the hardest work I've ever done, working with the Osteopathic Association, the Maine Medical Association, and then on behalf of the PAs. So yeah, this is the product of some of those compromises that were made. The PAs at that time, when we were modernizing our practice, we thought that after those 2 years where we would be under a collaborative agreement with a physician, we felt like we were ready to practice independently. But we could not reach agreement with the physician community at that time. And that agreement was really important to this committee at that time. And so what we finally were able to, we could live with was what the practice agreement requirement is right now. Unfortunately, what's happened over the last 5 years is the practice agreement has been put into practice, and you can hear the evidence. It hasn't particularly worked. It ends up being this administrative burden. It's expensive because in most cases, PAs are hot. They're going through these these businesses that specifically sell this practice agreement relationship. So it's not necessarily physicians that they've met or in the community or have deep knowledge or they have a relationship with. They're going to a company and they are using that company to find a physician willing to sign on to this practice agreement. So it's not, I would argue that it's not having the intent, I think, of what the committee at the time hoped, which would be a more authentic relationship in that practice agreement. So as we continue to practice and try to meet the needs of our patients and respond to the evolving landscape of healthcare, which is pretty scary out there, it's just become more and more a burden for PAs who feel very ready to practice independently and want to continue to be serving their patients if a hospital closes or a health center closes. So that's why we've brought this before you today. I would argue that this gets us much closer to true parity with NPs. Did that help?
I think, yeah, I mean,
Okay.
it was a fairly detailed question. I mean, like I said, there's a lot of, I know you guys did a lot of work on this. The committee did a lot of work on this 5 years ago. I think we arrived at a good compromise, but it sounds like I think my colleague to my right here may have another thought as well, so I will be quiet.
Representative Strachey.
Thank you, Madam Chair. And actually, it's longer ago than that because in the 126th, it was like one of the first bills that I was given, and it was about physician assistants. So been doing this a long time. And I understand it's that incremental change that needs to sometimes occur till we get to that point where we say, okay, they're still going to do their 4,000 hours under supervision because that's basically what it is. But all of those things, I've seen that progression and we come to a place where we can do that. And I actually feel like we're probably where we need to be to allow that. It doesn't seem to me that in the spirit of what we were expecting those collaborative agreements to be, they are truly not that when someone can just be a physician that's going to offer that to a bunch of PAs. And it's really just for the mechanics of a piece of paper and not for actually anything. And I'm concerned that we have an inflated sense of safety based on a collaborative agreement that really isn't doing anything. But I guess, are you satisfied in what the work that you've done with the PAs that they're in those 4,000 hours and even those 4,000 hours of supervision lead to collaborations when they're out on their own?
Yes.
I mean, those are important.
Yes, yes. And I'm nodding my head. I agree with everything you've said. I have to make one small clarification and this is confusing. I know, guys, but so collaborative agreements are the agreements that PAs have when they're under those 4,000 hours. We don't want to do anything to get rid of collaborative agreements. We are all for the collaborative agreement with the physician for the first 4,000 hours postgraduate. What we're trying to adjust here is the practice agreement.
I get it.
I know it's two different agreements. And the practice agreement is the one that it's post 4,000 hours, and it's only if you're in this narrowly defined healthcare setting. So.
And you agree that the reason that was a compromise for allaying the fears of people that are trying to do something, because what are we trying to do in the end? Ultimately it is to protect the public.
Absolutely.
Okay.
Yeah.
Representative Foley.
Thank you, Madam Chair. Thank you, Laura. So it's my understanding, if a physician's associate has a practice agreement with a physician and that physician, or the agreement ends for whatever reason, physician dies, moves away, whatever, does that mean that the physicians can no longer treat their patients?
I mean, that, so
I mean, all of a sudden,
honestly, I would have to really, I'd have to defer to Tim Terranova to understand, so he can answer the mechanics of it. But it's a huge fear among the PA community. Like, what if the physician becomes ill, or it passes away, or is no longer able to be on my practice agreement? So, I mean, you can't provide that care without that practice agreement. So, like, what happens, right? It's a huge question. I mean, ultimately, like, you have to find a new physician to do a practice agreement with because you can no longer treat those patients.
And that would be a concern of mine
Yes.
for the patients,
Yes.
not just for the physician's assistant, but for the patients.
Yeah.
I mean, I have an appointment tomorrow and all of a sudden I can't go. I
Yeah.
mean, that's not a good situation.
It is not a good situation. Yeah, it's just another example of how it, unfortunately, the practice agreement hasn't really worked the way I think people hoped it would work.
Representative Chimino.
Thank you, Madam Chair. So continuing along that same process, thought process, you'd also have to pay another fee once you get that once you get that new doctor to sign on to the agreement.
If you're using one of those companies that some of the PAs have referenced and that I referenced, then yes. I mean, we did hear from a PA who I don't think is using one of those companies who was able to find a physician through her networks that was willing to sign that practice agreement. But yeah, if you're using one of those companies, yeah, I think so.
Representative Orford.
Thank you, Madam Chair, and thank you for being here with us today. I'm making an assumption, I want to make sure it's correct, that a physician associate who goes out and starts their own practice and is practicing independently with this practice agreement, they are paid by insurance and their fees are higher than they would be if they were still back in working for a hospital. In other words, what they are paid themselves is higher than what they would be paid if they were still not an independent practice, basically.
I don't know that their rate of reimbursement or payment would have anything to do about, I don't know that that would be contingent on
Well,
them
that's-
practicing
to me,
under a
that's-
practice
yeah.
agreement.
Well, it should be if they're practicing independently and absorbing other fees versus having their organization absorb those fees. So, so I would like to know what the salary looks like for a PA in independent practice versus a PA not an independent practice. If there is a significant difference, what that might look like.
Do you mean, just
and
so
then
I understand?
Maybe I
yeah.
could answer something here. I mean,
Yeah.
typically you enter into an agreement with your insurance carrier for a reimbursable rate for whatever the provider is reimbursed. And maybe the hospital has a negotiation that's a larger negotiation option so that the provider gets paid whatever. But ultimately, as an independent provider, I would venture to guess that I'm not paid more than if I was working at a hospital. So and that's proprietary information.
Thank you.
Ultimately.
I am just interested in, so whatever you can find out for the work session, but if you can't find out anything, no. But the thing that's more important to me is how many other states are doing this, allowing for independent practice without any sort of practice agreement or supervision within that independent practice itself. And then what can you tell us about the data for where in the state of Maine, where these PAs, are they in fact practicing in the rural areas and the areas where we desperately need healthcare providers to be doing this type of work? Do we have statistical information that demonstrates that that's actually where they're going? So if we were to, I mean, because everybody talks about this, and I've been hearing this for the last 5 years, that there's this great need in our rural areas, but I've yet to see any data that demonstrates that as we make these changes, the practitioners are actually populating the rural areas. I'm not saying a few aren't, but in mass are going there and populating these rural areas and making a difference in the healthcare for the people in our rural communities. So I'm very curious about those two things, what other states are doing, and then some sort of statistical information that would demonstrate that over the last 5 years, as we've made these changes, in terms of allowing people to practice with just supervision and or practice independently, that we're seeing people moving to the rural areas and providing these services. So those are the two things I'd like to know more about.
So we're not currently allowing that without a practice agreement, but if I hear you right, you'd like to see if other states are doing that, if there's a higher percentage of providers reaching a rural area, because we're not currently allowing that without a practice agreement.
But we are, my understanding at least is that we are now allowing physician associates. It used to be, not too many years ago, that a physician associate worked directly under a physician.
Okay.
They couldn't do much without that physician authorizing it.
So I do
was
think
maybe
this is
6 or
getting
7 years
into
ago.
work session.
And now
This is
have-
getting into work
yeah.
session.
Okay, great. Super.
Yeah, thank you. Are Are
I'm
there
not sure.
additional?
I'm so sorry. I'm
that's
not
okay.
sure I
think it's-
understand the question.
I think we can probably talk about it.
Okay, okay,
at the
all right,
end of-
okay.
Yeah, thank you. Are there additional questions from committee members? Seeing none, thank you for your time. Oh, yes, Representative Clucci. Representative Arford, could you turn your mic off?
Thank you, Madam Chair. For scope of practice for physician assistants, is there any sort of, I mean, I just did a quick search, and are there any parameters other than, as long as you have the experience, you can practice it? I mean, I just am trying to understand are there any, do we have anything that says, okay, physicians associates can do these kinds of work. Nurse practitioners can do up to this kind of work. Physicians then need to do, from here to here, right?
Mhm.
Like, I'm just trying to understand, are there any lines there? And so if that's the case, why would anyone go to medical school if there's no longer lines? I just am trying to understand because there's so much. I'm asking in good faith.
Oh,
I'm really
yes,
just
I
trying to
know you are.
understand.
Yeah. Yes, there are lines. I think I understand the question you're asking because when I first entered into this work, I kept looking for that chart, right? That had like the column over here and the column over here and the column. The chart doesn't, there are lines, but there is no chart because it's way more complicated a question to answer. So I'm actually going to ask one of the PAs to answer that question for you because I don't feel like I can do it justice. But yes, there's definitely lines, but I don't feel ready to really explain exactly where they are and how they work. So I apologize.
Representative Arford?
Quickly. I just was thrown off a little bit when the chair participated in answering the question along with you that I asked. This is what I was asking, and I apologize for getting thrown off a little bit. There currently are physicians associates practicing in independent practice with these practice agreements throughout the state of Maine. That's currently in place. They are doing that, correct? With a practice agreement.
There are
Practicing
PAs that are
independently.
practicing medicine with a practice agreement with a physician. Yes.
Independently. They could be at their own little clinic, wherever they would like it to be. And as long as they have all their licensure in place to be a PA, and as long as they have a practice agreement with the physician, they are doing that practicing right now.
I guess I think that I would want to make sure that we're using the same language with the same definitions. When you say practicing independently, what do you mean by that? What we have right now is what we have in law, which has a very, very narrowly described clinical setting where the practice agreement is required.
Okay, this is what I meant.
And so I mean, you may ask a PA whether they practice independently and they may say yes, and maybe they're not maybe they're not in that narrow clinical definition for needing a practice agreement. So that's why I'm not quite sure when you use independent exactly.
Okay,
how
I
you
know
mean.
exactly what I meant to say. So they are practicing in a setting that does not have a physician, a MD doctor or a DO doctor present in it. And their supervision is happening through a practice agreement with a provider, a MD or a DO who does not actually practice at that site, because if they had an MD or DO practicing at that site, they would not need the practice agreement.
Yes.
Correct? So my question about whether or not people that are currently doing independent practice with a practice agreement in a site that does not currently have an MD or a DO, which requires them to have the practice agreement, if they are in fact populating the rural parts of our state.
Okay.
That was my
Okay,
question.
so
and I'm
of those PAs who are practicing with a practice agreement today, you want to break down geographically of how many of them are operating in what we would consider rural versus urban.
When you speak to us about them going into
Okay.
rural areas, and we're hearing a lot about the federal funds that are coming into the rural areas,
Yeah.
is that where we currently are seeing physician associates with practice agreements?
Yeah, it's a good question, Representative Arford. Honestly, I don't know whether our PA association can access that data. It might be a question. I hate to throw Tim put Tim on the spot. That might be a question for the board. Yeah.
I understand how tough this is, and I so appreciate you hanging in there with me. Thank you very much.
Additional questions from committee members? Seeing none, thank you for your time.
Thank you.
Are there additional people in the room that'd like to testify in favor of this bill? Welcome.
How do I get this? Is it on?
It's on.
Okay,
Yep. Just
very
make sure
good.
you sign in too.
Okay. So Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is David Wade. I'm a resident of Hamden, Maine. I practice emergency medicine, and I'm the founder and operator of Pine Tree Urgent Care, a startup urgent care practice currently in development in Bangor. I am here in strong support of LD 2088, an act to increase access to primary care provided by physician associates. Bangor and the surrounding region are facing serious gaps in both primary and acute care. In recent years, 5 local walk-in care practices have closed. Most primary care offices are not accepting new patients, or patients face wait times of up to 8 to 12 months, if at all. Working in emergency medicine, I see the direct consequences every shift. Patients who could be treated in primary care or urgent care instead come to the emergency department, creating crowding, delaying care for true emergencies, and increasing unnecessary costs for patients and government payers. I started Pine Tree Urgent Care with a few clear goals: to provide timely, lower cost care, reduce inappropriate emergency department utilization, and bridge gaps in care while patients wait to establish with primary care. One of the biggest barriers to expanding that care through physician associates is the current regulatory burden. Under current laws, PAs with more than 4,000 hours of clinical experience are required to maintain a practice agreement with an active physician when practicing in a non-physician-led clinical setting. These practice agreements typically cost between $750 to $1,250 per PA per month, regardless of whether any actual collaboration occurs. Nurse practitioners do not face this requirement, which creates a clear disincentive to hire PAs despite their training and capability. These costs further strain already thin margins, particularly in the context of stagnant or contracting CMS reimbursement rates and rising inflation. It's also important to note that many hospitals and for-profit urgent care centers, there is no physician physically on site. When additional consultation is needed, it is often done through specialty services rather than a supervising physician. This reflects how team-based care is already delivered safely in real-world practice. As a startup, Pine Tree Urgent Care plans to employ about 10 healthcare professionals. Our ability to operate depends entirely on stable practice agreements. If a physician discontinues an agreement for any reason, it would not affect just one provider, it would end our entire ability to practice without a grace period. Patient care would stop, and those jobs would be at risk. LD 2088 removes unnecessary administrative and financial barriers, allows PAs to practice to the full extent of their training, expands access to care in communities like Bangor, and reduces strain on emergency departments and lowers overall healthcare costs. Thank you for your time and consideration.
Thank you. Are there, yes, Representative Mastrofio.
Thank you, Madam Chair. Can you just give me a really brief, those 4,000 hours, can you tell me what the supervision looks like? And how that's different from the practice agreement that you're talking about now that you don't want? Do you understand? I'm just curious. You have to have those 4,000 hours and they have to be supervised.
Sure.
How are they supervised?
Yeah, so let's go back into training a little bit of PAs. So PAs are highly trained professionals. We train for anywhere from 24 to 28 months in a vigorous training program. And this goes straight through summers. We have clinical rotations that are similar to medical school, and this is about 2,000 to 3,000 hours on the books. My surgery clinical rotation was about 400 hours in of itself. Okay, so when we graduate, there's kind of this expectation that it's kind of like an apprenticeship. Like if you're to look at it, folks kind of start out and they're new, they're kind of fresh, they have a lot of approximate information, and then you're kind of refining that ability to practice into clinical practice. So you're taking book knowledge and you're going into the real world, per to say. So those 4,000 hours I feel, are important, largely because we don't have a residency. And I mean, what is really a residency? A residency is something that a medical doctor, a doctor of osteopathic medicine completes, that's on job training, So in a similar fashion, our job is kind of like our residency. So those 4,000 hours that we practice, that's the time that we have to gain experience and kind of get to this level where we can practice. I will say, that the scope of our practice isn't dictated so much by a scope of practice agreement. I go into the ER every single day. I don't consult on my scope of practice agreement to figure out what I'm going to do that day. I practice within my competency, the scope that I'm trained, and that's both academic and that's both on the site job training. That's within my capability. If anything, I'd say PAs are very aware of their scope, limitations, and that's how we practice medicine. I hope that answers your question. I hope I didn't go too far
I
off.
just was wondering how the supervision actually works. So
okay.
you have a patient
Sure.
and the physician in that practice that you're working in, and this is before you go out and practice on your own.
Yeah.
How does that work?
Yeah, so it's a mentorship, almost like an apprenticeship, just kind of what I was alluding to before. So you'll kind of come into practice, you work alongside of a physician or a physician available for consultation. And then you basically, it's kind of an extension of being a student, really. So you start out, you see a patient, you come back, you say, oh, I'm comfortable with this. You may run that by a physician that you're working with. And as that confidence kind of increases, you do that less and less. It's kind of like a baby bird learning to fly a little bit. But eventually they have to be ousted.
And that is no way like what these practice agreements are.
Yeah, the practice agreement is largely a regulatory piece of paper, and it's really a redundancy. So, I mean, we're kind of actually wrote an answer to this question too. So our scope of practice is really defined by training, credentialing, and employer, oversight. So we're not going to practice beyond what we're trained for. Malpractice coverage really dictates us too. So for instance, when you go to credential with payers, this could be Medicaid, Medicare, or private insurers. And when you get credentialed with a hospital and your privileges, you really practice within that scope. And that's not just true of physician associates. That's actually true of physicians as well. A physician isn't going to go in there and remove a gallbladder. They're going to practice within their scope of competency. Although there's legally no law that says that they can't. But you would be brought up upon the board and you'd probably lose your license. So we're kind of bound by that.
Thank you. Additional questions from Representative Clucci?
Thank you, Madam Chair. We keep hearing this phrase that PAs need to be able to practice to the full extent of their training. I don't really understand how they're not able to do that.
Those aren't my words. I would say that PAs are.
I mean, like everybody's been saying that.
Yeah. I'll expand because I think that's important, right? So no, I think that we are practicing in a large way to the extent of our ability, but we have this unnecessary regulatory burden, which is the practice agreement, which is really just a redundant piece of paper. The biggest barrier, I would say, having started a practice, is these practice agreements. While they're redundant, they're costly redundancies. So they're anywhere from $750 to $1,250 per PA, per provider. And as a business owner, if I hire an NP, I don't have to do that. They don't need a scope of practice. They can just start. So there's really no incentive for me to hire a PA. And like I said before, PAs are highly trained. I mean, 24, 27 months of education straight through the summer. It's like 3/4 of a doctorate in half of the time. So you're basically drinking through a fire hydrant. These guys are very passionate. They deliver great care within their scope. And they have lots of clinical hours, 2,000, it's 2,500 hours. And this is, extensive. So we're in family medicine, internal medicine, emergency medicine, surgery, pediatrics, OB-GYN, psychiatry, and our choice of electives. So we are trained as generalists, and we're ready to kind of, do this job. So I would say that we are, and I practice, to the full extent. But I would say that there's a huge barrier to opening a practice. you know, in Bangor, for instance. So we lost 4 PCHC clinics, which were all walk-in clinics. And then we lost Northern Light walk-in care. You know, and I think a lot of people are scared to open a practice because of that. And when you add this kind of regulatory burden and when you add these extra costs per, you know, PA, it becomes more expensive. And honestly, you know, like I said, it puts PAs at a disparity to NPs when it comes to hiring.
Thank you.
Yeah.
Additional questions?
Yeah,
Sorry, I'm
just,
long-winded.
No worries.
So also a lot of people have been talking about how, like I feel like people are saying that it's really hard for PAs to work. And so I'm wondering, like, I understand people are saying they want to be able to own and operate their own practices. But like, I feel like the sense is like PAs can't get jobs. Like, that's what I'm hearing from the testimony. Is that?
Yeah,
I
that's
mean,
accurate.
So PAs can't get jobs in hospitals and other practices.
Okay.
I mean, like, I'm just
yeah.
trying to
No,
understand where are PAs not able to get work?
That's a fair
That they
question.
need to open independent practices.
Yeah, so that's a fair question. And I would say that this goes across the board. This isn't just for private practice. This is also for when you go to work at a private practice. So let's say you own a private practice and you're looking to hire somebody. And one of those folks requires a practice agreement. And one of those people does not require a practice agreement. You're going to pick the person that does not require the practice agreement because it's less of an administrative burden and it's less of a financial burden. And I didn't realize that until I, you know, started the practice where it makes much more sense to hire an NP. I'm kind of losing track of your question a little bit. So if you want to repeat any parts that I didn't quite get, I can.
I mean, I think I understood. I mean, I think you basically repeated the same thing, which is like, it's your preference to be able to just work independently. Like, that's what this is about. It's not necessarily about that you can't find jobs. It's about the
Is that a
desire
question?
to practice independently, is my understanding. Is that correct?
Halfway. There's a lot of reasons, you know, and the biggest thing is it's a huge liability. So I own this practice, right? We're employing about 10 folks. And let's say for any reason the physician dies or they simply decide to end the practice agreement for whatever reason. Operations have to halt. Everybody stops. It's a huge financial liability. And it's a huge disincentive for them to open it up. Nobody else in the Bangor area has been willing to do what I've, you know, done because of the risks. You know, I've got my house on the line, my family. So, you know, why would you? I mean, it doesn't make all that much sense. To answer one of the other questions, your reimbursement is often less. It's 85% as a PA. It's not 100% of Medicare and Medicaid.
Thank you very much. Additional questions? Yes, Representative Olson.
Thank you, Madam Chair. Just trying to boil something down to a little bit more simplistic way of looking at something. The first 4,000 hours is more of a mentorship. Anything after that is a guarantee of contact. I mean, they're not doing anything other than guaranteeing that they're going to be available to take a phone call.
In relation to what's currently?
To this agreement. They're not agreeing to come in and do anything. All they're agreeing is to take a phone call. So you're paying for a guarantee of someone answering the phone. That's all you're paying for.
Let me correct that. Not even that. So all you're paying for is a scope of practice, a practice agreement that says you can practice. There's no requirement for them to take a call whatsoever.
Additional questions from committee members? Representative Barford?
And this is going to be very quick. I do not want to belabor this, but what you just said, because it was my understanding that the practice agreement for independent practice is in a contract between the physician associate and the MD, the DO. So you're saying that in that contract, the PA has no right to contact as needed with their physician?
It depends on your contract. So some contracts may, but some contracts may not. It kind of depends on who you're signing with, what your agreement with that physician is. But per my understanding, and I'm not a lawyer, my agreement says that you can. Okay. And we actually do enjoy a relationship with the physician that we have. And we're going to continue that regardless because that physician actually brings value to our practice. But depending on the practice you have, I'm not aware of any requirement beyond the scope of the actual practice that you're performing. So it's literally a scope of practice agreement, which, like I said, is already kind of covered by your credentialing, training, employer oversight, on the Board of Medicine. So if you're to practice outside of that boundary anyway, you'd be brought upon the board. So it's kind of it's a major redundancy, in my opinion.
Thank you so much for being here today.
Thank you very much for your time. Appreciate it. Are there additional people in the room that like to testify in favor?
Thank you.
Welcome.
Thank you so much. Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Angela Coton. I am an Augusta resident, an Augusta business owner, and a physician associate who has practiced medicine for over 16 years. I was also the first PA in Maine to open an independent medical practice under LD 1660 in 2020. So thank you for that. I'm here today in strong support of LD 2088, an act to increase access to primary care provided by physician associates. I began practicing medicine in 2010 and have worked in otolaryngology, facial plastics, dermatology, and aesthetic medicine across Maine, Massachusetts, and North Carolina. In 2018, I was recruited to Maine by Maine General to practice ENT, also known as otolaryngology. My husband is from Maine, and we chose to make our life here because we believe in the state and its communities. After years in hospital medicine, I wanted to serve patients in a more accessible, community-based way. What I encountered instead were barriers that had nothing to do with patient safety or my ability to practice medicine. Even after LD 1660 passed, I was still required to secure a collaborating physician, someone with no legal responsibility for my decisions, yet whose signature determined whether I could care for patients. I spent weeks making phone calls. Many physicians told me I had more expertise than they did in my specialty. Others declined because they saw me as competition. It was discouraging, and at times it felt like the system was protecting paperwork instead of patients. Eventually, my primary care physician agreed to collaborate with me, allowing me to open my practice in Augusta. Since 2020, my practice has served 1,800 Maine patients. They come from as far away as north of Bangor, and some drive over an hour and a half. While we do offer aesthetic services, a significant portion of my work is medically necessary care, skin cancer biopsies, chronic dermatological disease management, and ENT conditions like ear infections and sudden hearing loss. These are not elective concerns. They are problems that worsen when patients are forced to wait. Recently, I diagnosed melanoma in a 26-year-old female patient. She came to me because she couldn't get in to see a dermatologist because she didn't have a primary care provider to refer her. I partnered with a dermatopathology practice 5 years ago and am able to offer this necessary service for $100 cash pay to patients. Had she waited another year, her outcome would have been devastating. Once cancer is identified, I immediately refer to local surgeons. Collaboration does not disappear when unnecessary barriers are removed. It happens every day in real practice. More and more patients ask me to be their primary care provider because they simply cannot find one. These are not people looking for convenience. They are people looking for care. Maine's primary care shortage is not theoretical. It's happening every day in our communities. Physician associates are trained, experienced, and already practicing medicine collaboratively. What limits us is not competence, but regulation. I respectfully urge you to support LD 2088 for increased access to qualified medical providers and, most importantly, for the patients who cannot afford to wait. Thank you for your time and consideration.
Thank you. Questions from committee members? Representative Clucci.
Thank you, Madam Chair. Thank you. So your example here of referring the 26-year-old to a dermatologist, doesn't that suggest that it's really helpful to have meaningful practice agreements that are actually doing what they're intended to do? I mean, because that's what I read this to be is awesome. That's exactly why we should have something like that. So you have a direct path for somebody who does present with a more, a higher level care need, and you have a pathway to get them right to that specialist. So it seems to me that isn't there benefit, and why would
What is the question? I'm sorry. I'm trying to understand what the question is.
Your example, you have a relationship with somebody that you can refer people for the higher level care that they need.
Yes, there's a Mohs surgeon.
Provide benefit to you and your patients?
So a signature on a piece of paper from a primary care provider that allows me to have a practice agreement is not who I'm referring to.
Right, because what I'm trying to understand is like, this seems like if you're, let me ask you a question. Do you think this is the kind of relationship that the legislature intended there to be when this law was initially passed?
So I know within my scope of practice and my 16 years of medical experience that when I remove a cancer, this patient, depending on the type of cancer, either needs a general surgeon or a Mohs surgeon. So if it's a basal cell carcinoma or a squamous cell carcinoma, I refer to Dan Felitis at Maine General because that's who they need to go to. If it is a melanoma, they need a wide excision. So I then referred her to plastics. But having a signature on a piece of paper from a physician does not in any way increase my ability to understand that I'm still collaborating with other physicians, but it just depends on what that patient needs as to where I refer to. But I didn't reach out to the signature on the piece of paper and say, who should I send this person to?
Additional questions from committee members? Representative Arford?
Yeah, I want to thank my colleague because I think what we just discussed to me is a perfect example of potentially if the collaboration agreement had value to the physician assistant and if the relationship was actually one where they could count on their person they've contracted with taking their call, especially in the early parts of their practice, if they've gone right from this 2 years of supervision into independent practice, especially if it's in a rural area where there's not a lot of docs around, they may be looking at this cancer and they're not sure which one of those 3 it is. They just simply haven't had a lot of experience. So I'm
I
just
see
saying
what you're saying.
that's
I'm
when,
okay,
that's when
a
the collaborative
collaborating
agreement would come into play.
So my 4,000 hours of required experience allowed me to know where to send that person. I didn't reach out to my collaborating MD and ask them where I should send this person. And so I'm still collaborating daily with physicians around me, with PAs, with MDs. And for 6 years, I actually trained MDs, PAs, and NPs and DOs on how to practice medicine. So this is, it literally is a signature. I have never reached out to Genesis Watt, the MD, who signed the piece of paper for my practice agreement for any question on anything, because I don't practice primary care.
That sounds very challenging. And I hear that you're telling us that you did not find value in that relationship.
I think he's an amazing person and I think he's very bright, but I haven't needed his help. And that's great for me because I also find that many of my colleagues are not starting their own practices because they have to pay somebody who may or may not be doing anything for them.
Thank you. Additional questions? Yes, Representative Flynn.
Thank you. Thank you. Even though you don't reach out to them, you still pay them the monthly fee?
So the monthly fee varies depending on who a physician associate may choose to get as their collaborating MD in their practice agreement. So if, say you're me, you're struggling to find an MD to sign a piece of paper that says, I agree that you can practice. If you reach out to all of your colleagues and they say no, then you reach out to a company. And a company then determines how much you pay. And that can range. It can be $1,000 a month. It can be $1,500 a month. I'm very lucky in that my primary care provider understands the breadth of my experience and knows that I'm a bright cookie and doesn't charge me anything. He doesn't charge me anything because he didn't do anything.
But there are people out there who would be paying this fee and not ever needing to call.
Absolutely.
Thank you.
Additional questions from committee members? Seeing none, thank you very much for
Thank
your
you.
time. Are there additional people in the room that like to testify in favor? Thank you. Thank you.
Hello. Hello, Representative Matheson and members of the committee. I'm Bridget Quinn from AARP Maine. I'm an Associate State Director of Advocacy and Outreach. On behalf of our nearly 200,000 members in Maine, thank you for the opportunity to provide testimony and support. I'm going to keep my comments brief because I fear I don't have much novel things to say compared to everything you've heard or the lived experience of PAs. So AARP Maine has a long history of supporting the state's 324,000 family caregivers who make it possible for our older loved ones to age in place. And that is why we are expressing our support for LD 2008 to take steps to modernize the practice of Maine's physicians associates so they can practice in communities where we need them. AARP is fighting to improve access to affordable healthcare by cutting through red tape that could prevent PAs from doing their job. Patients across Maine should have access to qualified providers in a variety of settings, including hospital, medical offices, community clinics, long-term care settings, and in our home communities. Physician associates are a vital part of that care, helping to keep our older adults across Maine in their homes and in their communities while also keeping them out of costly facility-based settings. I will just leave it there. I'm happy to answer questions if you have them for me, but we are supportive of this and thank you for the opportunity.
Thank you for your time. Additional questions from committee members? Seeing none, thank
Thank
you. Are there people in the room that'd like to testify in favor of this bill?
I think I'm the last one. You're welcome.
Yeah, me too. Yeah. Go right ahead.
Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Kathleen Monaghan. I'm president of the Maine Academy of Physician Associates, a Dover Foxcroft resident, and I practice medicine and occupational health and urgent care. MIPA is a nonprofit organization that represents over 1,000 PAs practicing in Maine and the patients that we care for. Today, I am testifying on behalf of MIPA in support of LD 2088, an act to increase access to primary care provided by physician associates. The value PAs bring to the U.S. healthcare system is undeniable. PAs diagnose, treat, prescribe, and have an essential role in providing high-quality, evidence-based medical care. As valued and respected medical professionals, we remain united with our healthcare colleagues in a shared mission to provide safe and effective care to all patients and are rooted in our commitment to transforming healthcare in our country through patient-centered, team-based medical practice. Collaboration happens naturally through referrals, consultation, and shared patient care, not through mandatory signatures. In fact, many PAs often practice independently without oversight, frequently managing their own panel of patients as the sole provider responsible for their care, especially in rural areas of our state. You have heard from many of my colleagues today and many more who have submitted written testimony regarding the barriers they are currently facing in their practice, along with their desire to use their skills and expertise to help fix healthcare gaps they are encountering on a daily basis. LD 2088 is about one word: opportunity. Opportunity for PAs to serve their patients at the top of their licensure, training, and scope of practice without outdated and often expensive barrier that the practice requirement has proven to be for PAs working in non-physician-led clinical settings. Opportunity to expand services in rural areas of Maine at unprecedented times when specialty practices, urgent care centers, and even entire hospitals are closing throughout our state. Opportunity to become a solution to this problem for our displaced patients from these closures. Opportunity to help build a more efficient healthcare system in the state that we live in and that we love, where every healthcare professional can contribute to their fullest abilities. Opportunity to practice in the same way that our nurse practitioner colleagues have been able to for over 30 years in this state now. PAs see the gaps and want to play an active role in being a part of the solution. It's part of our clinical history, education, and our identity as PAs. Please allow us the opportunity to do so. I'll take any questions.
Thank you. Questions from committee members? Seeing none, thank you for your time.
Thank you.
There are additional people in the room who'd like to testify in favor of this bill. Seeing none, we have two online, Edna. Mr. Moyer.
Hi, can you hear me?
Yes, we can. Thank you. Welcome.
Great. Thank you so much. Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Daniel Moyer. I'm a homeowner in Kennebunkport, originally from Kennebunk, and I practiced medicine in Maine for 5 years. Today, I'm testifying in support of LD 2088, an act to increase access to primary care provided by physician associates. I've been a physician associate for 12 years, beginning my career as a PA in the U.S. Navy and subsequently working as a PA for the Department of Homeland Security as a medical contractor and in the civilian sector in the fields of orthopedic surgery, dermatology, and urgent care. In 2023, I started my own medical practice, Trinity Medical Group, LLC. In this business, I contracted with the state of Maine Disability Determination Services to perform Social Security disability physical evaluations. My relationship with the Maine DDS office and staff was excellent. My responsibilities performing these evaluations included reviewing medical records, obtaining a detailed medical history from the claimant, performing a comprehensive physical examination, and writing a detailed report on my findings and providing suggested limitations. I was able to perform these evaluations independently without any assistance or consultation with a physician. Unfortunately, because of Maine state law, I was required to maintain a practice agreement with a Maine licensed physician. Physicians do not provide this service for free. I paid close to $10,000 per year to have a physician maintain a practice agreement with me so that I could perform these evaluations. I used a private company to find a physician for the practice agreement requirement. The physician I hired was excellent and understood the burdensome requirement for a practice agreement and his role to help me fulfill the state requirement. The physician I hired was a Maine licensed physician, but located in Texas, and he was actually an anesthesiologist. I accepted the burden of having a practice agreement and associated financial obligation as just the cost of doing business in Maine. Sadly, the high cost of having a physician practice agreement was a significant and motivating factor for closing my business in 2025. Combining this expense with the cost of insurance, paying a medical assistant, payroll provider costs, accountant and legal costs, vehicle expenses, supplies, and other business expenses, taxes too, I realized it was not financially feasible to keep the business open. This was unfortunate not only for my family, but also my medical assistant's family and the Social Security disability claimants. Despite all the other business costs, if I did not have the cost of a physician practice agreement, I probably would have kept my business open, continuing to serve some of the most vulnerable Mainers and providing a good paying job to a Maine medical assistant. I hope that LD 2088 will pass, allowing experienced physician associates to practice without a practice agreement with a physician, and that you take my personal story into consideration when voting. Thank you very much.
Thank you for your testimony. Questions from committee members? Seeing none, thank you for your time.
Thank you.
Edna, we have one more online. Welcome.
Hi.
Hi, we can see you. We can hear you. Go right
Great.
ahead.
Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Megan Pudler, and I'm a Director of State Advocacy and Outreach at the American Academy of Physician Associates. On behalf of the Academy, I'm here to express AAPA's strong support for LD 2088. As you know, we've made great strides in the state of Maine over the last few years by moving away from supervision to describe the nature of the PA relationship with physicians and replace it with collaboration, as well as allowing for instances where a PA does not need a practice agreement with a physician. While we appreciate the legislature's work to ensure greater access to care, the requirement for a physician to sign a practice agreement with a PA in specific instances still remains an unnecessary administrative barrier that can delay or even prevent a PA from practicing. LD 2088 is part of the solution to bring greater flexibility to the healthcare system by allowing PAs to deliver care where they're needed without unnecessary administrative burdens mandated by the state. These changes would improve access to care for patients. As one of the fastest growing medical professions, PAs are positioned to make a positive and lasting impact on patient care. Public opinion research conducted by the Harris Poll found that patients overwhelmingly support PAs as part of the solution to address the shortage of healthcare providers. They recognize that PAs can increase access to care and make medical appointments easier to obtain. Maine would also not be alone in making these changes. In recent years, 7 states, Iowa, Montana, New Hampshire, North Dakota, South Dakota, Utah, and Wyoming, have passed legislation to eliminate the requirement for a PA to practice with a specific provider while maintaining team-based collaborative practice where appropriate. There are many others that are considering it this legislative session, including nearby Massachusetts and Rhode Island. Furthermore, a study, medical malpractice payment reports of physician assistants / associates related to state practice laws and regulations, published in the Journal of Medical Regulation, examined 10 years of medical malpractice payment reports, compared the laws and regulations of states for the same time period, and found that states with more permissive practice environments compared to restrictive states had no increased risk of PA medical malpractice payment reports. The research also determined that almost all PA practice reforms, such as allowing PAs to practice in collaboration or without a formal relationship with the physician, led to a reduction in medical malpractice payment reports for PAs and physicians. Further, as you know, the Rural Health Transformation Program, a federal investment designed to strengthen the rural health workforce, expand access to care, and modernize service delivery models through evidence-based, community-driven strategies, includes incentives for states to improve PA practice environments. LD 2088, if enacted, would bring the state of Maine from an advanced practice environment to an optimal practice environment, and therefore the state could benefit with further funds. LD 2088 directly aligns with the Rural Health Transformation Workforce goals and will increase the state's federal scoring methodology, which is tied to ongoing funding. AAPA is committed to improving patient access to care, removing barriers to PA practice, and improving the regulatory environment in Maine is an essential component of that. I appreciate the opportunity to be here today and provide input and look forward to addressing access issues in Maine.
Thank you. Questions from committee members? Seeing none, I apologize. I'm quickly going through my paperwork, but did you submit written testimony?
Yes,
Yes,
I
okay,
submitted
great.
it like right around 12:20, so it was right
Okay.
on the line.
Great. And will you have links for some of the stats that you had mentioned
Yep,
in
we
that
have all of
testimony?
that in the footnotes, and I was taking notes on some of the questions you have for the work group, and I'm working actually with our research team right now to get you some of those answers.
Great. Thank you very much. Appreciate your
Thank you.
time. There are additional people in this room that wanted to testify in favor. I just wanted to make sure I didn't miss anybody. No? Is there anybody in the room who'd like to testify in opposition to this bill? Anybody online, Edna? Yeah. Is there anybody in the room who'd like to testify neither for nor against this bill? Welcome.
Thank you.
Go right ahead.
Good afternoon, Chair Bailey, Chair Matheson, and members of the committee. My name is Liam Sego. I'm a research analyst at the Knee Regulatory Research Center at West Virginia University. Thank you for this opportunity to testify on LD 2088. Physician associates play a vital role in Maine's healthcare system. More than 1,300 physician associates are actively working in Maine today. And in contrast to the dwindling supply of primary care physicians available in a lot of rural communities, the number of physician associates is rapidly growing. Each year, the physician associate workforce in Maine grows by about 100 providers. And the surge isn't just benefiting coastal and southern communities. Franklin County has seen a 57% increase in physician associates in the last 5 years. Somerset County, a 27% increase, and Washington County, a 40% increase. And I've included a table at the back of my testimony with a sense of the geographic distribution across counties. To provide the best results to patients, Maine's physician associates need a regulatory framework that makes sense. Across the country, states are addressing healthcare shortages by removing legal obstacles that prevent medical providers from practicing to the full extent of their training and skills. Maine has been a leader in this effort, becoming one of the first states to grant nurse practitioners full practice authority several decades ago. And today, more than 2,300 nurse practitioners work all over the state providing care. More recently, Maine has allowed experienced physician associates the ability to operate their own practices, provided that they enter into a practice agreement with an active physician. The law also requires that a physician always be available for consultation. Repealing these restrictions would give physician associates more flexibility, expand access to care, and make Maine a more attractive destination for physician associates around the country. 5 states have already moved in this direction, dropping requirements that physician associates be supervised by or collaborate with a physician. Critics of these reforms have argued that physician oversight is essential to protect patient safety. This concern has prompted extensive research. Across many quality measures, including preventable hospitalizations, mortality, malpractice suits, and others, most studies have found that broadening scope of practice for advanced healthcare providers, including PAs, does not harm patients. I know this committee wants to make healthcare more widely accessible while also protecting patients from harm. The available evidence suggests that the reforms proposed in this bill would move Maine closer to this goal. Thank you, and I'll be happy to take your questions.
Thank you. Questions from committee members? Representative Harper?
Yeah, thank you, Madam Chair, and thank you for being here. When you talk about scope of practice, I think of scope of practice. So you're saying that being able to practice independently without a practice agreement is a change in scope of practice because you aren't adding on any new skill sets or any new services that you can offer other than the fact that you don't need to have a collaborative agreement with someone to deliver services.
That's right. I think of it as a change in the practice environment. And if
But
you
that
will,
would be considered a scope of practice change?
it might be a terminological,
Well,
quibble,
because
but
I just want to make sure the research that you quoted was
Mhm.
scope of practice.
it includes these types of reforms that impact to what extent physician oversight is required.
Okay. Thank you very much.
You're welcome.
Additional questions from committee members? Seeing none, thank you for your
Thank you.
time.
Good afternoon, Senator Bailey, Representative Matheson. My name is Ann Sedlak. I'm the Director of Advocacy at the Maine Medical Association, and I work alongside the Maine Osteopathic Association, and we are submitting testimony neither for nor against. Our professional associations and MIPA have a strong history of mutual respect when we disagree and collaboration when we agree. Regardless of the issue, we have sought compromise whenever possible. I am also so proud of our work together, including joint statements with MIPA, the Maine nurse practitioners, and others around the clinician perspective on the importance of vaccines, including the hepatitis birth dose and other issues. When we determine how to testify on a bill that would change the status quo for another clinician, we center our analysis on whether patient safety would be compromised by the change, not to gatekeep medicine, but rather to ensure our shared patients get the best possible care. For example, one of our major concerns is assuring that all members of the healthcare team are appropriately supported in their medical decision-making, especially just after training, and especially if choosing to practice in rural areas of Maine, where it can be isolating for clinicians to practice independently. We testify in opposition when we truly believe the bill would harm our patients if it passes. However, it is also hard for us to testify in support because our members are not neutral on these issues. They see countless bills on the scope of practice or scope of practice adjacent and see them as, quote, death by 1,000 cuts. Our members feel an obligation to defend the education and training required for an individual to treat patients in healthcare because they know how critically important their own education and clinical training would be. We weighed all of this when considering whether it is appropriate and in the public interest to reduce physician involvement in the PA's practice. Our associations have an obligation to articulate the importance of leadership roles of physicians in our healthcare system and patients' interest in physicians leading their treatment teams. However, we believe MIPA when it states that it seeks to achieve parity with nurse practitioners and how they can currently practice as the lead clinical provider in their practice. We believe that since the previous legislature granted this to NPs, this legislature can extend it to and should extend it to PAs. We appreciate MIPA's members promoting the professionals of PAs in our healthcare system and appreciate the opportunity to work together for the betterment of our patients. Thank you for considering our thoughts. Happy to take any questions.
Representative Mastracchio.
Thank you, Madam Chair. Do you think that physicians think that it's a good thing for a company to be able to provide a physician to merely sign a piece of paper, and that is the spirit of what the law was, what we sitting up here intended?
No. I mean, we keep getting this thing. It's just the physician signing a piece of paper. I have not heard any members who enter into these who believe that it's just signing a piece of paper. I think that that probably happens in reality because people are really, really busy. And you could say there's a lot of reasons for that, but I would say that no, we don't support that, but we do support getting paid for it. I mean, they are offering a service. It probably should be capped, but if these are in place, I mean, it's not, I understand that some of it's $0, some of it's really expensive, but some type of, you're going to have this. It's not crazy.
It almost seems like there's a circumventing of, somebody said, well, we could do this, and all they're asking for is a signature. I mean, I don't think that we envision that, is what I'm trying to say. And I can't imagine that most physicians, and I think that's why they may have difficulty getting somebody to sign up, because they take it seriously and they understand. To them, it means something different than a company. We often see companies spring up to fill a void.
Yes, we saw this in a bill from last session that was hard for us because we kept hearing that. But I agree with you, that was not the intent. I think when I wasn't in the role, but that wasn't the intent when this compromise was crafted, was it for it to be a money-making scheme. It was supposed to be helpful to patients.
Thank you.
Additional questions from committee members? Seeing none, thank you for your testimony. Oh, sorry, Representative Harper.
Yeah, thank you so much for being here with us today, and thank you, Madam Chair. I really appreciate it. I honestly find it mind-boggling that it seems as we're all in agreement that having some sort of a more knowledgeable than you, trusted person, that a PA setting up their own independent practice could turn to be their person to answer their questions or whatever. We all thought that was a good idea when we passed the previous law, but I haven't heard anybody say it's worked out like that. That's come before us today, has said that it's actually been of value to them. It's been expensive, which I understand their concern with that, but it really hasn't been of value in the way that when I know I voted for that law, I thought it would be. And so that's bothersome to me. And so I'm not sure how to get around that. I'm just saying that that's not good news to me, at least. And I don't know how to go forward with this bill and knowing that. So if you have any other comments to make on that, I certainly would appreciate them.
I respect everything I heard today. I think that I would not say that every agreement like this is terrible. I would imagine that there are some PAs that do like this. So I don't think, this is the hard part of the legislative process. No offense to you all, legislative time. It's really hard to get people up here to share diversity of experiences. So I would just say maybe that some people do like it. But if it's not working, if it seems like it's costing people a ton of money without any value, that's why we're kind of standing to the side for this. We respect MIPA. I think their president is an incredible advocate, and we don't want to get in their way if they feel like this is something that is going to advance their practice. We're in a tricky spot.
Thank you. Additional questions? Seeing none, thank you for your testimony.
Thank you.
There are additional people in the room that would like to testify neither for nor against. I thought I saw you over there in the corner. Yes, thank you. Sorry.
Right. Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Tim Terranova, and I am the Executive Director of the Maine Board of Licensure in Medicine. I am here today to testify neither for nor against LD 2088. Bolum licenses and regulates allopathic physicians and physician associates in Maine. It fulfills this mission by licensing, regulating, and educating physicians and physician associates. As a little bit of background, LD 1660, an act to improve access to physician assistant care, was passed as an emergency bill in March 2020, and the rule implementing the changes was finalized in December 2020. The bill allowed physician associates with more than 4,000 clinical hours to practice without a physician partner as long as they maintained contact with the collaborating physician and had a practice agreement approved by the Board of Licensure in Medicine or the Board of Osteopathic Licensure. Based on this implementation, Maine has the second highest rating of advanced for physician associate practice in the nation, as defined by the American Academy of Physician Associates. And I know that that was a question. There's actually a United States map in the back of my testimony that shows which states have advanced and which have optimal. The testimony in favor of LD 1660 indicated that the bill would allow physician associates to expand access to safe, cost-effective, and high-quality medical care in rural, underserved areas of Maine. Between February 2021 and June 2025, Bolum has approved 55 practice agreements. As you can see on the attached map of Maine and table, 17 of those agreements have been for aesthetic practices. 17 provide insurance exams, so no treatment or diagnosis, and 21 have medical practices, although 5 of those provide short-term seasonal coverage on Monhegan Island. With the exception of 2 aesthetic practices, there are no practices east or north of Bangor. LD 1660 has not had the intended impact of expanding access to patient health care in rural, underserved areas of Maine. LD 2088 asks the legislature to remove a level of oversight that was recently reduced for the same reasons offered in LD 1660. When considering this bill, the legislature should consider if the previous change had the expected results and if the requested change would impact those results. If passed, the Board of Licensure in Medicine would not be able to track the impact as there is no notice or reporting requirement included in the bill. In addition, the legislature should consider if the changes as a result of LD 1660 caused harm to patients. I want to be clear that based on the limited data, the answer is no. There have been no quality of care complaints among those 55 practice agreements. As the legislature considers reducing regulation for physician associates, Bolum urges the committee to consider what impact deregulation may have on access and patient safety. Thank you for the opportunity to provide these comments. I'd be happy to answer questions now or at the work session.
Representative Foley.
Thank you, Madam Chair. Thank you very much for the information. The chats are great. Well, you state that 1660 didn't have the impact of having more physicians in the rural area. Could that might be because of the needing for the practice agreements?
It absolutely could. That is a possibility. That is something that we have heard, that the practice agreement, it is hard to find a physician. I'm not going to deny that. It is hard to find somebody to sign on. So we have heard that as a reason that people aren't practicing. Will that change practice in rural areas? I don't know. I mean, you can see where the people who got physicians are practicing. It's in southern Maine generally.
Yes, sure.
Thank you. So if we were to pass this bill and put some sort of a reporting requirement in there, this would be able to be tracked for that information?
I'm not exactly sure how, but if there was a reporting requirement, we would try to meet it.
That's a great question.
Good
The
answer.
to that was-
Good answer.
You've done this a few times.
Additional questions from committee members? Representative Barford?
When I was, refresh my memory, you just told us, but I was writing so much I didn't capture that. 1660 passed which year? It was
2020.
Yeah. So, and then the second bill that we just discussed passed when?
This is the second bill
Right,
that
no,
we're
no, no,
discussing.
I'm sorry. The nurse practitioner bill, because we're talking a great deal about that as
From
well.
what I've heard from testimony and others, I'm not an expert on nurse practitioners, but it sounds like it was about 30 years
Right,
ago.
but we just, okay, I don't want to go in that direction.
Okay.
This is what I wanted to say. based on you, by the way, this is excellent data. Thank you so much for this. This answers some of the questions I was looking for, but I'm still not sure when you talk about the quality of care and you talk about that there have been no no reports of any reduction in quality of care. How would someone report that?
So what I mean by that is that there have been no complaints by patients about quality of care to the board,
Complaining to who though?
to the board.
Oh, to the board.
Yes.
So how might a patient know even that they could complain to the board?
That's a great question. We have a website. We're part of the state government. We try to do some outreach. It's limited. It's the same way they know any board exists.
So you don't require the practices themselves to do any sort of evaluation of their and report to you? There's no
We don't
requirement
license
for any sort of-
practices. We only license the
Right, I know
individuals.
that. So in other
we-
words, there's really no in-house system for patients to report on quality of care that you would be aware of, that you would have access to.
And I think that depends. I mean, certainly hospitals and health systems have their own internal complaint systems that patients can take advantage of. They have patient representatives. I think your smaller practices, I think it depends on what they're capable of.
No, but would you have access to that information?
If the patient filed a complaint with us,
That
we
would
could,
be it.
we could request information about their history, the practitioner's history, the licensee's history, but we would not go out and proactively look at somebody's history.
Thank you very much for this.
You're welcome.
Additional questions from committee members? Seeing none, thank you very much for your time.
Thank you.
Is there anybody else in the room that would like to testify neither for nor against this bill? Does anybody in the room want to testify on any level for this, for, against anything? Nope. Great. Does the committee need any information for the work session? Seeing none, we'll close the public hearing for LD 2088 and open up the public hearing for 2128. An act to reorganize the Emergency Medical Services Board to implement the recommendations of the Blue Ribbon Commission to study emergency medical services in the state, presented by our Senator Bailey. No? Okay. Presented by our department.
Somebody wrote David, but can you fill that out?
Yeah.
I'll be back.
Interesting is that just something.
No, I just need.
I'm going to introduce
About to take that home.
anybody who would like to testify in favor of LD 2128.
Thank you.
Mm. Oh, yeah. Welcome.
Good afternoon.
Good afternoon.
Feels like it's been a long time and also a short time since I was in front of this committee. It's nice to see you again, and I hope to see significantly less of you this year. Although I appreciate you all very much, and I wanted to thank Senator Bailey for her sponsorship. I'm here today before the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. Senator Bailey, Representative Matheson, and honorable members of the committee. My name is Will O'Neill. I'm the Director for Maine's Emergency Medical Services, and I'm here today in strong support of LD 2128, a department bill. This legislation represents the next critical step forward in implementing the Maine EMS Board's 2035 vision and two-year strategic plan, and operationalizes the thoughtful recommendations of the previous Blue Ribbon Commissions on Maine EMS. By streamlining the current Maine Emergency Medical Services Board, reducing the number of non-regional appointed members from 12 to 5, This bill creates a more agile and efficient leadership structure, something we were told to do. Current board is designated and designed to promulgate rules and shape policy. Board can continue that core focus while reorganization preserves essential expertise by maintaining representation for dispatchers, municipal administration. We actually want to amend that line to say municipal fire department administration, EMS administrators, paramedics, and technicians, leaving maximum room for us to continue our important partnerships and representation from Maine's fire and EMS departments. This move to improve the efficiency and agility of our existing Maine EMS board has been in planning for some time. It's a component, as I said, of our 2035 vision and mapped out in the 2023 to 2025 two-year strategic plan for Maine EMS. This bill contains the second part of a two-phased approach that is not merely administrative. It builds support for a more responsive and future-ready EMS system for all our Maine citizens. Furthermore, LD 2128 strengthens the vital link between our regional councils and our state-level oversight by requiring regional councils to regularly advise their board representative on local concerns and policy. We ensure that the diverse needs of Maine's geography are still heard at the highest level. The bill's requirement for an annual report to our committee of jurisdiction by January 1st creates a transparent mechanism for continuous improvement, allowing for proactive legislative adjustments to Maine's emergency medical services system. Again, after conferring with my colleagues at the Maine Fire Chiefs Association, we would suggest that we amend page 1, line 17 to read Municipal Fire Department Administration. I believe that simple change will actually help us preclude any work groups. Glad to provide support for any work sessions on this topic, and I'm happy to answer any questions. Thank you for your time today.
Thank you, Ms. Representative Clucci.
Thank you, Madam Chair. Can you help me understand what problems have been created by having such sort of broad and diverse representation on the board?
I wouldn't say the problem was with broad and diverse representation. It was really about positioning. So we received post-evaluation ASME survey, an M-STAR survey, and then 2 Blue Ribbon Commission reports, which I believe are actually attached in another set of testimony you'll see, that directed us to move to create a licensing board to remove the investigative and adjudicatory components of the current Maine EMS board off their workload. We've since done that in the last session that's been established. And now the second phase of that was to reduce this work for the board down to its more core functions to promulgate rules and provide suggestions to the system. So we really looked kind of, the analogy I would use is as an arborist. My direction was we need to trim this tree. You can pick a chainsaw or you can get an arborist. And we really looked at the existing seats on the board, how to transition those out, who still needs to be most represented. And then most of all, we brought in a second component, which is when the legislature provided the positions for us to have state-supported regional models, we have 4 regional managers now that manage 4 regional advisory councils, 1 in each section of our 4 regions of the state. Those have 17 members on those councils, and that's where that representation now will go. So we're streamlining the core Maine EMS board, but broadening what we're able to get from our stakeholders at that same time. I hope that answers your question.
Additional questions from committee members? Seeing none, thank you for your testimony.
Thank you for your time.
Is there anybody else in the room who'd like to testify in favor of this bill?
Good afternoon. Nice. All right. Good afternoon, Senator Bailey and Representative Matheson and distinguished committee members of the Health Coverage and Financial Services Committee. Thank you for the opportunity to speak today. My name is Mike Senecal and I serve as president of the Maine EMS Association and senior director of Maine EMS. And I had the privilege of serving on the Blue Ribbon Commission to study emergency medical services in the state. I'm here to express my support for LD 2128 and which implements the key recommendations of the Blue Ribbon Commission. The commission determined that the current EMS board structure no longer reflects the realities of Maine EMS system and recommend the restructuring to ensure proportional representation across all service models, including the profits, non-profit, hospital-based, municipal, volunteer, fire-based, and non-transporting services. LD 2128 fulfills this recommendation by modernizing the board's composition to better represent today's EMS landscape and strengthen regional input into statewide decision-making. This restructuring will also allow the board to be more nimble and responsive and align with its true statutory intent to serve as an executive oversight and system execution body for emergency medical service in Maine, ensuring that the governance is more balanced and efficient, reflective of the needs identified throughout the commission's work. Thank you for this consideration, and I'm happy to answer any questions. And I'd also add, I support the amendment that Director O'Neill presented to.
The addition of fire department.
Correct.
Thank you. Questions from committee members? Seeing none, thank you for your testimony. Is there anybody else in the room that would like to testify in favor of this bill?
I don't have a written one any longer. Good afternoon. My name is Brent Levy. I'm the Fire Rescue Chief of the town of Wyndham, also currently serving on the Maine EMS board as the Maine Fire Chief's representative, and would support the bill now as amended, whereas the majority of emergency medical services are provided by fire-based EMS. So unless you have any questions specific to that, my testimony has since evolved.
9 seconds. Very good. Any questions from committee members? No? All right, you're sitting down. Are there any other people in the room that would like to testify in favor of this bill? There's nobody online, right, Edna? Is there anybody in the room that would like to testify in opposition to this bill? Is there anybody that'd like to testify neither for nor against this bill? Seeing none, does the committee have any questions for the work session? Seeing none, we will close the public hearing for LD 2128 and open the public hearing for LD 2133. An act regarding licensing and community paramedicine services and clinicians. I think we have someone to present that for us. Again, welcome again. No. Okay, all right. Go right ahead.
Good afternoon. I apologize. I briefly considered bringing a second Coke just to switch in the middle, but also I would like to point out that we have added a draft committee amendment, even though we worked very closely with our DHHS partners on the bill. The final bill had a strike through that they just felt made them uncomfortable, even though it didn't change the bill at all. So we unstruck the strike through. That's all the amendment did. It didn't change the bill or anything else. It just worked to alleviate their concerns. We had moved a definition further down in the bill, but my DHHS partner, Director Monteo, found that reading the bill, he felt hearing it sooner made more sense, and it didn't change anything at all for us. So we went ahead and made that change. And thank you, Senator Bailey, for the prompt response from your office in doing that. Good afternoon again. Senator Bailey, Representative Matheson, and the honorable members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Will O'Neill. I'm the Director of Maine Emergency Medical Services, and I'm here today to testify in strong support of our department bill, LD 2133. This legislation represents a critical step forward in formalizing and safeguarding one of the most innovative structures and sectors of our pre-hospital healthcare system, which is community paramedicine. By moving from a 10-year-long pilot-based framework to a formal licensing structure, we're ensuring that these services, which we provide as episodic, proactive, and preventive care in non-emergency settings, are held to the highest standards of quality, safety, and professional oversight. LD 2133 provides the necessary statutory definitions and licensing requirements to ensure that community paramedicine is practiced safely and effectively across our state. And more to the point of those definitions, the bill establishes clear definitions of community paramedicine clinician, and community paramedicine service. These will be vital requirements in our continued efforts to seek reimbursement for these services on a federal level. EMS clinicians in Maine are already required by the board to be licensed. LD 2133 ensures that they hold a separate but concurrent EMS license for community paramedicine that requires completion of specialized education and training for the expanded role. Having a separate set of standards, certifications, agency and clinician licenses, and regulatory oversight are the crucial components of any discussion that moves these efforts into a formally recognized CMS-funded service. Lastly, and very importantly, this bill emphasizes coordination with our home health partners to ensure that our care is episodic and doesn't duplicate existing general home health care relationships. The structural refinement is not merely administrative, it's an investment and a more responsive and future-ready EMS system to meet Maine citizens where they are. By supporting these technical rules for licensure, we protect the public while allowing this vital field to grow. I'm proud to provide any support for work sessions on this important bill and happy to take any questions you may have. Thank you.
Representative Clucci.
Thank you, Madam Chair. I'm curious if you could expand more on wanting to ensure that the care remains episodic. And I'm asking because I understand not wanting to duplicate home care relationships that are being reimbursed, but there's a lot of people that can't qualify to have home care reimbursed. I mean, you have to basically be on main care. And so I'm curious what the rationale was for, trying to narrowly focus it there. I guess what I'm trying to wonder is understand is if we make it episodic, does that mean that really it's going to limit access for this to be a way to help people stay at home and manage their care at home if they need a little bit of help, I guess?
I think I really understand the heart of your question, and it's important because that word episodic is something that we worked with really hard with our home health partners. Episodic is vague in the language. It may not show up several times in different episodes. It could mean what essentially we're trying to stay away from is if you have a chronic care condition that home health nursing can provide a resource for, that's the appropriate venue. But if you're in an area that doesn't have that, we want to be able to still provide those levels of care so you don't have to go somewhere else. We can bring that care to you. And that's our partnership with DHHS to ensure that our community paramedicine providers have extra levels of training, including the mandatory reporter and other pieces that home healthcare requires. But we had to negotiate essentially with them that word episodic in the definition, because otherwise we're creating a new thing and it kind of falls much more firmly under a DHHS regulation, but it is very much a pre-hospital environment set of work. So that was a compromise that I think actually works well, because in some sense, the vagueness of it allows us to do the very things that you're talking about, right? Is it really doesn't impede a number of times we could visit. It's really about if this other resource is available, we should only be used episodically. If it's not, episodically could occur very often. And that's kind of how we see it. This is, I think, a very crucial component of our efforts to be able to absorb some of the losses we're going to see from federal funding. And more to the point, community paramedicine, as it moves forward as an industry, we've got to find ways to pay for that. That is reimbursement and service that's vital to those communities where we have it. We've got 20 community paramedicine agencies here in Maine right now. They keep people out of the hospital. They make sure they follow up after their care. They assess fall risk. They do medication reconciliation, and they do it at a much lower cost than picking up and taking to the hospital to do all those things. The only thing we don't have is federal reimbursement. So the big change that Maine has made over the last couple of years was we pushed all those things into place: curriculum, standards, certification, license levels, and now regulation, so that we're one of about a dozen or so states that has that all in line. When CMS goes to say, how do we pay for these services? Maine Care has definitions. We've got definitions. And then we say, here's how. That's our hope. So this is part of a larger kind of infrastructure building discussion, but these components to broaden community paramedicine and allow them to happen this way are really vital. Another piece of things that we talk about a little bit is requiring affiliations and licensure, and that is to protect our communities, right? So a trend we're seeing nationwide is in areas that don't have regulation, third-party agencies for community paramedicine will come set up shop. If they're not regulated, they don't have to say anything to the local agency. They don't have to have medical directors in the same way. They don't have state oversight. But what they do is change the equation. We're not sure what kind of care they provide. We're not sure how often, and they could potentially be impacting those local services. Here in Maine, we want as much good care as we can get. So as an example, I'll use Biddeford. If I'm Medic ABC and I want to bring a third-party community paramedicine service into Biddeford and set up, I have to liaison and affiliate with that Biddeford Fire Department or EMS agency. So we have medical direction, we have components of quality, and we have regulatory oversight so that those things can all still happen, but they don't happen in a vacuum the way that we've seen in some of our in some of the other places in the United States, like Utah, for instance.
Additional questions from Representative Clucci?
Thank you, Madam Chair. Can I just ask a follow-up question? So there has to be a mandatory collaboration with the fire department. Can you say more, or the municipality? Can you just say more about
There
that so I can
has to
understand
be an
it?
affiliation that allows a medical director, an EMS medical director through the EMS agency. And then there's always a primary care provider that the community paramedicine agency establishes a relationship with. So this just formalizes, like, if we're going to come into Biddeford, we need to have medical direction that's a part of the system there in Biddeford that understands what we're doing, how the patient population works, and how those things are interfaced in that way.
Additional questions from committee members? Seeing none, thank you for your testimony.
Thank you for your time today.
Is there anybody else in the room that would like to testify in favor of this bill?
All righty, good afternoon. Thank you, Senator Bailey, Representative Matheson, and the distinguished committee members of the Health Coverage and Financial Services Committee. And thank you for the opportunity to speak today. My name is Michael Senecal, and I'm the president of the Maine AMH Association and senior director of Maine Health EMS. And I also had the privilege of serving on the community paramedicine stakeholder group that convened at the direction of the legislature to evaluate the current landscape of the community paramedicine in Maine and develop the recommendations for its future. I'm submitting this testimony in support of LD 2133. This bill is a direct reflection of the work, findings, and consensus reached by the stakeholder group. Among the most significant conclusion of our group was the need for clear statutory definitions and establishment of the licensure standards for community paramedicine clinicians and services. These were identified as essential to ensuring consistent, quality, and appropriate oversight in the future reimbursement across the Maine's healthcare and insurance systems. LD 2133 addresses this need by defining community paramedicine clinician, and community paramedicine service in statute, and establishing licensure requirements with minimum qualifications, training, and safeguards. A key theme highlighted in the stakeholder report was the urgent challenge of sustainability and reimbursement of the Maine CP's program. Maine CP's program have operated for more than a decade, originating as pilots in 2012 and have demonstrated clear value to rural, aging, and medical complex population. Yet they continue to rely heavily on grant-funded municipal subsidies and volunteerism due to the lack of structured reimbursement pathways. The stakeholder group heard directly from insurers and MaineCare that they cannot build reliable reimbursement models until the CP is formally defined and licensed with clear standards and clinical expectation. LD 2133 provides a regulatory structure they require to move forward. It does not dictate reimbursement, it enables it. From an operations standpoint, LD 2133 also incorporates several of the specific safeguards and standards identified in the stakeholder report, including background checks, mandatory reporting training, medical oversight by both EMS medical direction and primary care medical director. These requirements align directly with the stakeholders' consensus regarding What is necessary to ensure delivery of safe, high-quality episodic care statewide? For these reasons, I believe LD 2133 represents the logical and necessary next steps in the evolution of community paramedicine in Maine. It faithfully implements a stakeholder group recommendation and establishes the framework needed for Maine care and commercial insurers to advance reimbursement models and provides consistent standards that protect patients and support EMS agencies across the state. I respectfully urge the committee to support LD 2133.
Thank you. Questions from committee members? Just had a quick question. I know that the previous bill, you were going from 12 to 5 on the board. How does the board feel about a new licensing requirement and its duties around that? Do they feel like they will have enough personnel to help to move forward with the new licensing requirements?
Well, and that would fall now under the new licensure board that's set up outside that executive EMS board.
Got it.
Splitting some of those duties.
Thank you.
Welcome.
Additional questions? Seeing none, thank you very
Thank
much
you.
for your testimony. Is there anybody else in the room like to testify in favor of LD 2133? No one online, right, Edna? Is there anybody in the room that like to testify in opposition to LD 2133? Is there anyone in the room that would like to testify neither for nor against? Seeing none, does the committee members have requests for the work session?
Thank you, Madam Chair. What would be so helpful for me is to have a visual of Maine EMS and the new board, you know, what's being proposed as the new board, so we can actually see the structure and like, you know, who does what. So that would be just really helpful. I find it so confusing.
I would start by just saying, when you say Maine EMS, you're already talking about 3 different things, and that makes it confusing at the outset. We did put together a PowerPoint for new boards and committee members that I think will do exactly what you're talking about. Be glad to do.
Super. Any additional requests from committee members? Seeing none, we will close the hearing for LD 2133. And what's that? Oh, yeah, I think we have some language review, right? Colleen. Yeah, no problem.
Yes, again. Think down. So there were 4 amendments that the committee previously voted on that I wanted to bring back to you for their initial language review as they move forward through the process. The fiscal office has not yet completed the final fiscal review, and the revisor's office hasn't completed their processing. You'll see that again before it gets reported out, but we typically look at it first and just to make sure it's reflecting what the committee's vote was on each of these bills. So Edna's bringing them around. There's 4 of them. LD 1502, LD 1530, LD 2030, and LD 2060. So I'll give her a sec. I should have collated them while the hearings were going on. I just didn't think about it.
I'm speedy. You are speaking. Listen up. Taking notes.
Thank you.
It's in maths and we'll be right back.
There she is. Just say that out loud. Outdoor voice. We're gonna have a fun caucus tonight.
I think I'll start with LD 1502. This is the most straightforward because I really just like cleaned up a couple of typos from the version that the committee saw when you voted this. This is based on the sponsors amendment that Representative Moonen presented to the committee when you took the vote on this bill. This was a 12-1 report. You'll see the voting sheet for the divided reports. I attached the voting sheet so you can see at the back, but 12 members voted in support of this amendment, which would make some changes to the requirements for health insurance coverage for prostate cancer screening. It maintains the existing definition of what services qualify for coverage, the digital rectal examination and the prostate-specific antigen test. But what it does do is it removes the specific language in the statute that requires coverage at least once a year for men age 50 years of age or older until a man reaches the age of 72, and replaces that language with language that requires reimbursement for those services I mentioned if recommended by a physician when supported by medical and scientific evidence according to the most recently published nationally recognized clinical practice guideline. And it also puts in place a definition of nationally recognized clinical practice guideline. So you'll see those changes made throughout all of the sections in the statute, in the proposed amendment, which would apply to individual and group health insurance coverage. It also would prohibit cost sharing for those services and would also maintain the exception that the committee has put in place when you remove cost sharing for those policies and contracts offered for use with health savings accounts. Because there are some specific requirements related to those, but does preserve the ability that unless the IRS determines that the requirements are permissible for high deductible health plans, otherwise it sort of carves those out, consistent with what you've done with other mandated benefits. And then it also would propose moving forward that this would apply beginning with plan years, January, on or after January 1 of 2027. So that's LD 1502. The second one is LD 1530. This was a 661 report. You'll see that the 6 members voted ought to pass as amended. So that's the first amendment you'll see. 6 members voted ought not to pass, and 1 member voted ought to pass as amended. So what you have on yellow are the 2 amendments. The first amendment, which was supported by the 6 members that I mentioned there, and you'll also see the voting sheet at the back. This would provide a specific requirement for reimbursement for non-transporting emergency medical services beginning for health plans on or after January 1 of 2027 at the 160% of the Medicare rate. So it would enact a new provision in the statute that provides for reimbursement for these services. It would maintain in current law the requirement for reimbursing ambulance services at the 200%, but the committee might recall the discussion. There were proposals to go higher. So that's what this amendment does. It preserves in the original proposal that the committee asked the Bureau to look at requirement that carriers reimburse for the administration and dispensing of naloxone to both ambulance service providers and non-transporting emergency medical services providers. It requires that
or puts in place a provision that says a carrier may not be required to reimburse twice for covered services when both an ambulance service provider and a non-transporting provider respond to the same request for emergency medical services. This also would apply beginning for plan years beginning on or after January 1 of 2027. The second amendment that you'll see, which was supported by one member of the committee, is essentially the proposal that the Bureau of Insurance did their mandate review study on, which would increase the reimbursement rate for both ambulance service providers and non-transporting emergency medical services providers to 300, from 200% to 300%. And then also would require those same provisions requiring coverage for naloxone. And it has that same caveat that the carrier may not be required to pay twice for the same services. That's LD 1530. That's all good. The last two are LD 2030 and LD 2060. These were both unanimous committee reports, and both of these amendments just simply add emergency preambles and emergency clauses to each of those bills. I think in reflection of the committee's unanimous support. So fairly straightforward, but
Okay,
wanted to make sure you saw them.
right. Anything else, Colleen?
I don't have anything else. Busy day tomorrow.
Put on your work boots. I've had no requests. Yeah,
I can say that we have the interpreters for the first bill, LD 2087, so hopefully that will remain first because we
Right.
have them coming to assist with the work session. So that's my only request, that you do that one first. Whatever you want to do after that.
yeah, and then
is fine.
Representative Matheson's bill, she's not available from
10:50 to noon.
10:50 to noon, so we're just gonna have to play that one by ear. So we may move that to later in the afternoon, so that she can be here for that. But other than that, I've had no other requests for taking things out of order.
Thank you.
And on my two bills, hopefully you've seen, I did put forth some amendments. Those have been shared by Colleen, so if anyone has any questions on those, I'm happy to answer them. I think that's it. Great. All right. We'll see.